Okay, Secretary Galley, maybe you'd like to say hello and we'll move
Yeah,
into the logistics.
perfect, Karen. Thank you, and good morning to all fellow commissioners and the public who's joining for our December meeting of the Healthy California for All Commission. As we have for quite some time, we're holding the meeting virtually. And Karen, I'm going to turn it to you to set some ground rules, tell us how the meeting's going to go, and then we can even just go ahead and jump into roll call if that's okay.
Wonderful. Okay, so welcome everyone. Just to go over the virtual meeting protocols, as you all know, this meeting is being recorded. It will be posted on the Healthy California for All Commission webpage later today or tomorrow. Commissioners, as you know, you have the opportunity to mute and unmute and be on camera. Please do mute yourselves when you're not speaking to reduce background noise. If you could use the raise hand feature, if we're starting a queue in terms of discussion, you'll find the raise hand feature at the bottom of your Zoom screen. If you click on reactions, you'll then find another button that says raise hand. Members of the public, welcome. You're in listen in mode. You will have the opportunity to speak and provide verbal and written comment at the end of the meeting today. We'll give some more instructions at that time. You're always welcome to provide written comment at the email address healthycaforall@chhs.ca.gov. All public comment, written and verbal today, will be part of the public record and posted as a transcript to the webpage. We also have live transcription function enabled today, so you can follow with closed captioning if you click on the live transcript button at the bottom of your screens. Okay, moving on to roll call. Please, as I say your name, if you could just unmute and say hello to everyone, I'd appreciate it. And we'll start with the chair of the commission, Secretary Galley.
Good morning, everyone.
Carmen Comsty.
Hi, good morning.
Jenny Chin Hansen.
Good morning.
Bill Shao.
Hello, everyone.
Rupa Maria.
Good morning.
Bob Ross.
Good morning, all.
Richard Scheffler.
Good morning.
Andy Schneider.
Morning.
Sarah Phlox. Commissioner Phlox, I know you're there. Are you able to unmute?
Morning.
Good morning.
Me now?
Yes, perfect. Thank you. Kara Desert.
Buenos dias.
Antonia Hernandez.
Good morning, everyone.
Anthony Wright.
Good morning.
Richard Pan.
Present.
Jim Wood.
Good morning.
Michelle Boss.
Good morning.
Don Molds.
Hello.
And is Sandra Hernandez here yet? I believe she will be joining us shortly. And I just wanted to make a note that Commissioner Peter Lee gave us advance notice that he's unable to attend today. All right, with that, I will turn it back to Secretary Galley.
Thank you, Karen and commissioners. Thanks for joining this morning again. Before we get into the meat of the conversation, which as always is exciting and come together nicely, just want to share a little bit about where we're heading over the next critical few months. Karen, if we can get the slides back up. And before we go into that first slide, I just want to take a moment and acknowledge that I am in receipt. I think all of you also were CC'd on a letter from Assemblymember Talra and many colleagues from both the Assembly and the Senate who requested that the commission look at some of the financing and the planning around AB 1400. I think we are committed as a commission to continuing down the road that we are as we enter these last couple of meetings with the final report looming and the outline coming next and work over the beginning part of next year on this. So I will be writing a letter back to the authors of that letter to me, but I just wanted to acknowledge the receipt of it, acknowledge that many of you have seen it, if not all of you have seen it, and that we will handle it accordingly. So thank you for sort of those who reached out about it and know that it's on our radar. So I want to maybe go to the next slide, please. So today, to spend a few minutes framing where we are and where we're heading, We will then go into about 40 minutes or so on a follow-up conversation on long-term services and supports. Jenny Chin Hansen is going to give us some opening comments, given her expertise, her track record, and her knowledge in innovations in long-term services and supports. And then we'll have a bit of commissioner conversation about following up, building on what we saw last month in our conversation. And then we're going to spend the bulk of our time, roughly around 11 o'clock, hoping to transition into a conversation with all of you about ensuring a smooth transition towards unified financing. And I'll tee that up a little bit more in just a moment. Could we go to the next slide? So just review this. Some of you have seen it, but we are hoping by next week to have a outline for the final report to all the commissioners. Again, this will be an outline, a brief outline. It is meant to sort of make sure that we have all the big buckets, all the categories, that the potential concept for flow of the report makes sense. I know the content's going to matter a great deal, but getting an outline out to all of you is going to be helpful. If there are comments on the outline, please share those with Vishal by the 20th of December. We are also anticipating sending shortly a follow-up survey. That survey will build on prior surveys, try to get additional clarification where there was clear, not disagreement, but maybe either some confusion or need of clarification. We will try to elucidate that, as well as add a few additional questions around priorities and principles and values that have emerged from last meeting and this meeting, so that we make sure that those are reflected in our thinking and get incorporated into the report. I think between the meetings and those surveys, really the content for the report, and I am certainly, as in today, hoping that we get to touch on a number of issues that are germane to the report, and we will use the survey to flesh some of those out as well. Then we'll take the next 4 to 5 weeks. Myself and the team will work hard over the end of this month and beginning of January to put together a draft report to provide to all of you for feedback and comment. We will try to give you a number of days, if not hopefully nearly 2 weeks of time to be able to review that report before we come together for what will be a rescheduled January meeting. We're working to get something at the end of January, date not exactly pinned down, although I think they've ironed out a few people's calendars to make sure that a date or two could work. And we'll try to get that out to everybody ASAP so we can participate in that meeting, where we will spend a bulk of our time talking about the report and sort of the flow and the content, et cetera. And then after that meeting, we plan to have another meeting in February, final meeting, where I hope so much of the feedback and the input on the final report gets incorporated, and that we could review it one last time to then anticipate getting it out shortly after that in a bigger, broader public way. So that's sort of our timeline. I know it's ambitious. I know we're asking a lot of all of you. And so in advance, thank you for your willingness to help us get to a product that I think we can all be proud of. As I said, we anticipate things sort of picking up as soon as next week. We know many of you are tired from your day jobs, that you've all worked incredibly hard, like so many people I know at the state. And so I hope that this schedule allows some downtime as much as humanly possible over the holidays for some of us. Rest assured that our consultant team and myself will be working on the draft so that when we do send it to you in January, it's as complete as I think it can be by then. Okay, move on to the next slide, please. So I want to tee this conversation up as we come back to this long-term services and support conversation that we really touched on briefly in the last meeting. I think there were a number of good comments throughout our commission meetings about the primary need to focus on long-term services and supports. I appreciate the analytic models having taken this into account as an option We sort of had with and without long-term services supports, cost sharing, some other elements. But this, I think it's just an opportunity to dig in and try to understand where we can go with long-term services and supports in our broader move to a system under unified financing. So I know, before I go into these details, we know that unified financing on its own won't change the total trajectory around long-term services and supports. It can go a long way to help make certain things more certain things more reliable, but it doesn't necessarily transform the system per se. And almost, we learned so much during the pandemic, but one of the areas we really learned a great deal about is our long-term services and support systems here in California, whether those are in congregate care settings and in more institutional settings, or even in our home and community-based services settings, and the need to continue to evaluate those services on their value, their quality, their reach, their impact on equity, what they have to do with isolation, especially for older Californians and people with disabilities. So as we have talked about throughout this commission, what we are really hoping to get with a unified financing approach is not just a simpler, more straightforward, and hopefully affordable way to fund our healthcare delivery system, but also a new system that focuses on certain values and propositions that this commission has really lifted up. So we're going to start a little bit with a conversation with Jenny, a presentation really just 10 minutes or so on what her experiences have been and where she sees opportunities to innovate and move forward sort of with and under unified financing, but even outside of that. And I just want to highlight a few things the state has done and is doing before going through this slide. One of the important projects that we created that I think there's a lot of national excitement about is this Office of Medicare Integration and Innovation at the Department of Healthcare Services. It's small and mighty, it's just picking up. It's not meant to focus only on the duals or those with Medicaid involvement, but it's really looking at what many call the missing middle, those who are Medicare beneficiaries or soon to be, who aren't part of the Medicaid system, but still have struggle with meeting some basic life needs, getting connected to social supports that, frankly, in the Medicaid system, we have tried to create those tentacles and connections very deliberately. Not always in the Medicare space is that done. So really, this office is primarily focused on how we support Medicare beneficiaries. Even though it's not a state responsibility in the program, it's really ushered and brokered by federal arrangements. What can we do at the state to really make those connections more meaningful and sticky? We also created the Aging and Disability Resource Connections process, which for the first time created or will create a system where you had a central location where people in California can get information about everything from long-term care settings to other support services and community supports, whether you're a family member or somebody in older California or somebody with disabilities. We hope that that is going to be a system that helps make warm handoffs, creates a real no wrong door approach, and makes connections for people who otherwise wouldn't have services met. And then lastly, I just wanted to mention that in our CalAIM work, which is under consideration by CMS now, and we're working hard to get that negotiated, there'll be a number of changes in the years to come on how Medicaid is one of the primary payer, frankly, of skilled nursing and other long-term care facilities in the state begins to shift and move its efforts around. So this is an area where we know there's a lot to talk about and a lot to do. There's a lot being done. I think the master plan for aging, which many of you had a hand in, was a tremendous effort that elevated the work in this space. But today we just want to spend a little time there. So the analytic assumptions and implications that were modeled It's really based on assumptions that Congressional Budget Office laid out, that this benefit would likely be available to those with one or more limitations of ADLs or IADLs. The benefit would seek to cover both community-based, so home and community-based, as well as institutional long-term care. The focus would be on having no cost sharing in this program, and that the CBO estimates that this benefit would increase national health expenditure by about 5%. And so the consulting team built those assumptions into how we laid out what the presentation showed last month. And we also know that, like many of these calculations and forecasts and estimates, that there's a considerable degree of uncertainty that must be fine-tuned as we go and as we build both the plans and the bridges from where we are today to where we hope to go tomorrow. So with all of that as a backdrop, Jenny, I'll invite you to jump into this conversation, please. I think you are first to come to mind because of your tremendous track record and history in California and nationally thinking about these. Everywhere I go and talk to people in this space, your name comes up as somebody who's really been a trailblazer, and not just in thinking about the policies, but also your work on the ground over years of actually getting the care delivered to folks. So with that, Jenny, I invite you to take a little time and share with us your thoughts. And then I'll pick on a couple of other commissioners just to get their thoughts on this before we open up discussion.
Thank you, Secretary Galley, for the introduction and for our ability to take a few minutes to cover this particular topic as to whether it's in or out. And needless to say, I've showed up in a couple of conversations in the past meetings to indicate how I think it's important to have it in. And I'll just convey a few factors that I think compels me to advocate for this. One, because this is unified financing with capital letters, as I call it, for the entire California population. One thing that's no surprise to any of us is that the population of older adults and people living with disabilities is growing at a clip that I think would be inappropriate to not include. And one is the sheer demographics. About 1 in 5 of individuals in the state now already are 60 and over, and it's growing at a fast rate. And especially that many people don't realize, the people who are 85 years and older. This is the fastest growing demographic. And because of that, the nature of people's circumstance from an age standpoint, the longevity is a wonderful gift, but with that gift comes some other weighted perils, and that is, for example, being able to care for oneself, having more health conditions, as well as I'd like to highlight, because it was a topic I just mentioned briefly before, that more of us will have cognitive losses, as well as, if not full-on Alzheimer's diagnoses. And when you put that all together, people do use healthcare, but they also need assistance to live their lives as safely and as dignified as possible. For especially for our members who are attending and listening to this, I appreciate Secretary Galley indicating I have some background, and it is about 40 years from a nursing perspective, to designing programs, to advancing policy, to sitting on Medicare Policy Commission, and advocating really to elevate this topic. I think oftentimes it's the tip of the iceberg. we focus oftentimes of access to healthcare, and often that means getting to see a doctor, making sure we can get to a hospital if we needed, using emergency rooms. Well, that is like the tip, but this population oftentimes, not just the older population, but people with disabilities. And I want to talk about two. I was asked to give the human-centered perspective to this. Who are the people who would need long-term services and supports? And simplified, I put it in two categories. One, people who may be living their lives, but a life-changing kind of event occurs, such as a car accident, a major fall, a stroke that changes one's calculus on living. All of a sudden, you might have used care episodically and preventively, but something like this changes your life forever. And a lot of medical care happens, but what doesn't get really oftentimes expressed is the kind of support that makes it possible for you to live safely with good clinical steadiness, as well as a sense of doing your everyday lives. You heard the secretary speak to the qualifications, perhaps, of the insurance being activity of life that people would do. So from eating to bathing to going to the bathroom to even walking, these things are not clinical diagnoses. These are functional aspects. So category one would be these sudden life episodes that change. The second category of long-term services and supports to think about are children who are born with disabilities, for people who have behavioral health issues over the course of time, and then also people, as I mentioned, as the population grows, who have cognitive issues, along with oftentimes 5 or 6 medical conditions, taking a lot of meds. So, and these people are growing in a quick number. Oftentimes we talk about them in parallel with nursing homes or assisted living facilities. Bottom line is, I think we cannot ignore that. So we have two groups, as I just simplistically say, sudden life events that create a need for long-term services and supports, and people, whether born with or over time, develop these chronic needs. So I was asked what might be a good example of care. Ideally, I give you this one example. When I was in PACE and I was involved with this program for now about 40 years, I take the metaphor of what happens in a hospital at Friday afternoon at 4 p.m. with an older person. All of a sudden, they need to get discharged. So what happens to people? It's not the clinical care. It's basically helping one transition from a hospital environment to a home, and all the things that make it possible for them to come from this high intensity, highly supervised care to suddenly being at home. So what is that gap? That gap could be filled by what we call long-term services and supports, making sure that they have food when they go home, they can get transported to go home, that the medications are there, they have somebody to know how they're doing over the next 24, 48 hours. This is not something we normally think of clinical covered services, but it is what makes it possible for somebody to live safely, both clinically as well as functionally. And this is a huge underbelly. There are programs in the community like adult day health services, home health agencies, and especially direct care workforce. If somebody is qualified for in-home support services, the healthcare and supportive care worker is there. So these are costs. But these are oftentimes not designated as clinical fee-for-service services. But without them, people will oftentimes, and this is what they return back to the hospital quickly, and the clock starts again, both in the treatment as well as the costs. And so it requires a transformative way to think about it. as we talk about transitioning in unified financing a little bit later, I just want to elevate that the care delivery system has to have a transformative approach. These are not medical services, but this actually would mitigate unnecessary medical services. So I think that what I want to just convey that a few endpoints to my comments here. I think long-term services and supports is a sleeper issue. Oftentimes it gets left off. I'm so glad Secretary Galley highlighted some of the things that are going on right now at the state level. And I would also see that we provide the link to a whole chapter of work that was done by the Master Plan for Aging on long-term services and supports that gives obviously a much more robust, deep analysis of where we are today and what we could do in California. It doesn't get visibility, but just knowing that people who often fall in this category is a small percentage, perhaps 5% of the Medi-Cal population, but nearly 50% of the costs go to this population. So that's why I think it's important. And I think a canary in the coal mine indication of why this is important for healthcare costs. Interestingly enough, many of you are aware that long-term care has had an insurance industry behind it. This industry had started more than 20 years ago with lots of companies, but now there are barely a handful of companies left in the marketplace. And that's because of the cost issue. So that's why I think this needs to be in. I highlight finally that the older population is the fastest growing, and the 85 plus is the fastest population in entire demographic, even as proven in the latest census. And I again highlight those of us who are lucky enough to make it to 85, 40% will likely have cognitive issues, including dementia, and that has direct costs on healthcare. Finally, what is the end goal that I would love what's a good system produce? I think it produces a peace of mind that people can live as well as possible, manage the challenges that they have, avoid unnecessary care in hospitals or EDs that are not good for their well-being, but certainly not good on resource use and our clinical expertise. And it gives families a chance to stay engaged, not only with the care of their loved one or friend, but also it allows them to work. Because as you know, we are losing many people to the workforce because of care responsibilities at home. Employers are feeling challenged. So bottom line is, I do think we are all touched by this, and many of us actually have direct touches with individuals and loved ones who have been affected by dementia. It's a growing area. It falls under long-term services and supports as one of the categories that it's not just medical services. So I make the case that it's an important consideration because if we avoid it, it's going to show up in another way. And those costs will show up in healthcare, use of clinical resources that may not be necessary. So because I've done this work in Medicare and Medi-Cal, I'd say I've done unified financing with lowercase, not the big case, but understand it could be, the money can be well used, people's quality of life and quality of care can be increased, satisfaction, and even last comment I'll make, during this pandemic, those individuals who were in a program like PACE experienced less than 2% of the deaths that occurred for others who were in nursing homes or assisted living. So when you think about cost in the larger sense, as well as access to care and high functioning health and well-being, long-term services and supports, I feel, have a role. And I finally just want to thank, I remember I think almost our very first meeting, Commissioner Pan, that you brought up that this was an important area. And I hope that we can see that this is not just about medical or clinical services. Thank you.
Many thanks. First, let me, the queen of the understatement, you were 40 years of experience. When I said you have some experience, yeah, so sorry to undersell the tremendous track record and career you have. Just pick up on a couple of things that you said. When I came to my role here as a pediatrician, somebody focused on families and younger people, this was an area where I was not as well versed, and quickly, because of you and many others, and the primary role of the master plan for aging and its real sort of power during my time as secretary, have seen this as such a critical issue. So I'm grateful for you calling it the sleeper issue, because I think it is. And one way or another, it's sleeping and sneaking up, if not really hitting us pretty hard as a state, trying to realize what's coming given the trajectory of the population and some of the cognitive needs that older Californians are already having, and more are on our radar. So I think it's important to think of it as a sleeper issue, and I think this commission is trying to wake it up and keep it front and center for us. And then the notion that really the peace of mind is one of the goals. I think when we look at surveys and polls of what people are concerned about with healthcare, this is a related issue. You're right to say it's not all healthcare; it's life care in many ways. But this is one of the areas that I think many Californians either are struggling with today or concerned about in the future. So the commission taking this head on is really important. I'm going to pull in two people to the conversation next and then open it up. Still trying to finish up wrapping this up by 11. So that gives us about 25 minutes to reflect on what Jenny shared with us, other comments or ideas, even based on the meeting from last month. But Michelle, you are director of GHCS, our Medicaid system for the state, and Jenny, you were right that they pay for more than half of the days in long-term care facilities, closer to 2/3, I think it gets to. So it's a significant investment by the state, and I think with the transformations planned under CalAIM and just your experience, I know you worked hard when you were at agency to really protect and think about the needs of individuals during the pandemic in long-term care facilities. Would love your reflections on what under unified financing we might push for or think about when it comes to LTSS and our frame there. And then after Michelle, Antonia, I would love to pull you into the conversation a bit on how this is a really important equity issue, how families and communities struggle with figuring out long-term services and supports, how the language and the cultural incongruency with so many of those who need such services, how that might be improved as we think about this system of the future. So Michelle, you first, then Antonia, and then I'll open it up to the broader group.
Great, thank you. Yes, more than 2/3 of long-term care patient days in California are covered by Medi-Cal, so it's really an important issue for us to think through. And I think one of the things we're trying to do with CalAIM, and kind of similar with the unified financing, would be having one entity that's really responsible for the entire continuum. So, really incentivizing keeping people at home and wrapping around the services and supports they might need to stay at home as long as possible, as long as they wish to, as we think about the continuum, really incentivizing that and having someone really be held accountable for kind of ensuring that members and individuals get the care they need where they want it. And what we're trying to do with CalAIM and the carve-in of long-term services and supports to manage care is to do that. Additionally, we have a couple of community supports or in lieu of services that we're adding via CalAIM, and a few that I would specifically recognize would be the transition of nursing facility or diversion from nursing facility entry into assisted living facilities such as RCFEs or residential care facilities for the elderly, and really recognizing we need to ask individuals, where do they want to be served? Where do they want to live? And try to wrap around and provide services and supports that can do that. Similarly, environmental adaptations or home modifications, whether it's just a guardrail or something that might be needed for someone to live at home, I think is what we're really trying to do. So I think those are things that are top of mind for us as we think through what the long-term services and support kind of continuum here for the Medi-Cal population. One of the things that we proposed a couple years ago in a May revision was this long-term and home type of benefit. Really, individuals can live at home and be served at home, and how do we ensure that we do that? And some of our ideas with the home and community-based spending plan are reflected there. So some thoughts from DHCS.
Great, Michelle. Yeah, thanks for raising that. I remember the proposal well. We felt, especially in the pandemic, where we saw people who were deeply impacted. Jenny, you shared a stat I wasn't aware of, the relative mortality rate based on whether you're at home or in a facility. I know it's a complicated issue, but the feeling that we didn't have the facilities quite right, that more people wanted to be at home, and we as a state needed to move towards making that a reality and possibility. And then one thing I know that we have talked a little bit about related to kind of the innovations of the moves that Michelle mentioned is the workforce. There's been a tremendous amount of transformation and thinking around IHSS and the supports and the training and the resources that wrap around those IHSS workers and their beneficiaries, but also just the overall workforce opportunities and challenges in long-term care, I think is something that California and this commission, as we talk about workforce generally, will need to keep in mind. See number 3 commissioners' hands up. Antonia, before I get to the others, love to hear your thoughts on the question I posed.
Well, first of all, I want to thank Jeannie for bringing up this really important issue. It's not only an issue of equity, it's an issue of economics. And this particular issue hits not just the poor people, but middle-class people. It devastates their lives economically when they have a disabled child or an elderly parent that you need to take care of. And so I think that if we're going to look at this issue from a holistic perspective, from an equity perspective, we just need to acknowledge that just looking at the medical health needs of an individual, particularly a disabled elderly individual, it's not enough. And I think that we would be foolish not to address this issue. As our population ages, this issue is going to become much more important. And cognitive issues are going to become very important and very expensive. And I would say that if you really want to take care of your loved ones, it's only the very few wealthy who can afford it. It destabilizes families. People have to leave their jobs. Women are taking care of a child and a parent. So to me, if we really want to deal with an equity issue, this is an issue that needs to have attention and thought and be included in anything that we do. And at the end of the day, the few literature that I have read is that it's cheaper to provide the services at home than it is at a hospital. And so Jenny, thank you so much for bringing up this issue. It is a critical issue. Thank you.
Thanks, Antonia. Okay, with just under 20 minutes left, I'm going to go in the order I saw the hands pop up. Richard Scheffler, then Richard Pan, and then Carmen Comstein. So Richard Scheffler, go ahead, please.
Thank you, Mark. I think Jenny has made a compelling case, and I'm all in for it. And Antonia is quite correct that it is a lot cheaper to do it at home. The rough numbers now, if you go into a nursing home in California, it costs about $120,000. If you go in an assisted living facility, it will be 100, and home health care is 60,000. So we definitely, just looking at the numbers, we want to incentivize people to be able to function at home. The surveys I've seen and my own personal view, we all have personal views of themselves and my relatives, is we'd rather be at home. And I think the vast majority. So I think there is some sense of, we have to consider cost of costs, and but we also need to understand that by not providing it, there is a cost. You mentioned hospitals, but the cost to these families and the lost wages from working and the time, I would encourage the commission to monetize those and subtract those from the cost of the program, because those are real costs to the state. When people can't work, or they work fewer hours, there's lost productivity. The business community will understand this when their worker can't perform because they have to take care of a loved one. So I'm all in on this, but I do think we need to think more carefully about the nursing home industry in California. It's far from perfect, and the quality of the nursing homes that we have here, there's a lot written on it. I've read a lot of it, is not good. The report card is not good. So I would be wanting to, at the same time, have the commission talk about, if we're going to put this in and have nursing homes included, we also talk about improving the quality of care of the nursing homes that we're going to spend our public money on. But I'm all in and thinking about this as part of what we want to cover under unified financing. Thank you, Mark.
Thanks, Richard. Just two flags. I think your last point is exactly one of the opportunities we have with every aspect of this commission's work, is not just to think about how is it sustainably financed, but how does it deliver on the values and propositions and the goals that we have. And I think it applies to long-term services and supports. And I was negligent to remind folks, I think all of you received it, but for those in the public, that we did share with the commission a year ago, actually September 2020, after some time, Milliman did produce a report for DHCS in the state around the situation with long-term services and supports, highlights a lot of this. And we shared not the full report, but Appendix B, which looks at some of the conditions and situations here in California, but also highlights two state efforts, one in Washington that really starts to kick off this year, this coming year, and then one in Hawaii. And then it goes through how similar challenges around long-term services and supports have been handled in other countries throughout the globe. One observation I'll make is that those countries that have had a long commitment to some social involvement in the long-term services and support opportunities for their citizens have seen the finances sort of ricochet around a little bit, and they've renovated and reformed their original approaches. Things that started in the 60s and 70s got updated and refreshed in the last couple of decades. So I think the notion that it's iterative and it's moving around a bit based on what the expectations and frankly the technology and innovation on what can be done in and outside of facilities, I think is really important to consider, and one thing we should keep on our mind. But please take a look at that report if you have interest and haven't already. Okay, Richard Pan, please go ahead.
Thank you. And I too want to thank Jeannie for her wonderful presentation, and certainly fully agree with her that we need to include long-term service and support as part of our discussion and whatever plan we come up with. I would just make note that this is something I worked on in the state Senate, and one of the things, for example, we pointed out when we were looking at talking to the Department of Aging and Finance is that now the underlying assumption is that we basically try to provide the same level of services as we had before, but given the aging of the population, that what we should be spending on LTSS services as a state in order to just tread water, given the changes in the population, is an increase of 5% per year. 5% per year. All right, if we do less than 5% per year for LTSS services, then we are cutting services in terms of the financing. Now, that doesn't take account of, if we come up with better innovations, other types of approaches, that might be more, but I just want to put that into the context of this is just based on demographic change alone. And that's certainly fast growing, faster than our GDP is growing. So but I do want to point that out because I think it's important that as we're projecting out, and I think it was pointed out by both Jeannie and Antonio and Michelle, but there's a tremendous need for this, right? So we both talk about seniors, but we also, I'm a pediatrician. We have children with disabilities. Their ability to actually even live full lives and pursue a career is dependent on having access to these services. Because and in fact, oftentimes, the reason Medi-Cal takes care of has 2/3 of them is because we don't really have an alternative way of financing it. We're just basically telling people to spend down and go on Medi-Cal unless you have to be very, very wealthy. I would also point out that we need to address many of the workforce issues. If there's one field, there's probably other fields we can point to, but this is certainly a field where people are tremendously underpaid. We have a CNA shortage, and pay for CNAs. We look at IHSS, and we've worked hard, and I do appreciate the administration over the years trying to roll back some of the cutbacks. But it's a field where the financial rewards, let's put it this way, are quite minimal. I mean, you do it for your heart, not because you're going to be making any money. And frankly, the amount of money you get paid barely gets you, barely keeps you afloat. So that's something else we need to address as well. So the fact that 2/3 of our nursing home care, but it's not just nursing home care, it's in-home care, is financed through Medi-Cal, and God bless Medi-Cal, but it's not the greatest payer in the world. So when we think about how much we should be spending on long-term services support, we're underspending, and so as well. So those are some of the things we need to also address. But I don't see how we can say we're coming up with a system without including LTSS in there. We can't, leaving that out, which unfortunately has been happening over and over again, I think is unacceptable, just because we're still leaving people in the lurch in the end, especially as our population ages. So thank you, and I look forward to us incorporating this into our work. And again, want to really thank Jeannie for her really wonderful presentation.
Thanks, Richard. Before Carmen, you go, I just want to highlight, I think we'll wrap up with the last four: Carmen, then Rupa, then Don, then Sarah. And before Carmen, you go, just want to acknowledge that Sandra Hernandez has joined us. Sandra, good to see you. Thank you.
So yeah, thanks so much for raising this topic. I live in the East Bay. I live right down the street from the Ed Roberts campus. I think I have to represent the East Bay here, and this is where the disability rights activists have been organizing for decades. And this is where the community first movement started, and people with disabilities, they should be able to live with dignity and independence in their communities, to have long-term services and supports. And we absolutely should include it in any system of unified financing. I think in terms of the equity issue, I think, one of the major problems that we've had with eligibility for home and community-based services, for long-term care, for long-term services and supports, is that the bar is really high. People go into poverty and in order to get onto Medi-Cal just so they can get these services. It's absolutely horrendous, and we can't create these huge barriers for people to get long-term services and supports. So I think it's really important that we have, and I think in the slides it said, if you have one need for instrumental activities of daily living, or activities of daily living, you qualify. And I think we should keep eligibility very, very simple for long-term services and supports, and I think, I want us to remember with the continuity of care, that, it is a combination between of medical and healthcare services and other supports. And we can't create tiers of care where, we're pushing long-term services and supports onto unlicensed family members and creating that burden on them. It's not just about paying the people who provide these services more money. We absolutely need to do that. They need to be paid not just a living wage, but even more than that. We need to free up, we need licensed professionals in the home and community-based services. We can staff up our regional centers so that people can get community-based services. And we can't, create a tier, a separate system for people living with disabilities or seniors. And I really want us to emphasize that we can't, we have to work on these workforce issues. We have to invest in the healthcare workforce so that when folks are going to people's homes, when people are getting community-based services, they're getting it from folks who are trained. I've seen a lot of family members struggle. They're told to do wound care, and and a couple days later, they have a family member with bed sores and festering wounds. It's not something that we should take lightly. We can't create these tiers. So I really want us to remember that it is an equity issue. If we get more licensed people, more nurses, train more nurses to be able to do these types of services, we free up time, particularly women who have taken up this burden of caring for family members. And it's absolutely important. And, as everyone has said before, the modeling that has been done, Ken Jacobs talked about this last month. In the long run, we're going to be saving money. And I think that's really important, particularly when we're emphasizing home and community-based services, rather than, waiting till everybody is sick enough to go into acute care. And I'll leave it at that. Thanks.
Thanks, Carmen. Rupa next.
Yeah, thank you, Jenny, for these thoughts and important perspectives that you're bringing up. They're really a whole system of care is what we need for our chronic users of healthcare, people who need that support. As a hospital-based physician, I can tell you the number of people I've seen languish in the hospital because they have Medi-Cal. So first people are spending down to qualify for Medi-Cal, then for whatever reason they get hospitalized and they might need 24-hour care for a period. They languish for months in the hospital and the system ends up eating that money. A lot of our nursing homes in the Bay Area won't take those patients because they're prioritizing the private insurance patients. And so this just highlights for me the need to not have a mixed system where there's different tiers and categories financially of how patients appear in the system. The other thing I want to say is you raised that statistic that 40% of people over 85 years old will get dementia. I just want to highlight, thank you for bringing that up, that dementia is not a facet of normal aging. Dementia is a neuroinflammatory condition that is exacerbated by things like air pollution, by stress and debt, of which medical bankruptcy, personal bankruptcy, medical debt is the major cause of personal bankruptcy. So for our system, our healthcare system, not to exacerbate further things that we're trying to treat is important to think about. Also, the impacts of structural racism have been seen to be an independent variable impacting people developing dementia, and the impacts of a toxic food system. So as the state gets involved in the financing of the healthcare system, to really look at the ways in which we can make sure our aging population has a better chance of not getting dementia. The last thing I just want to say is the bringing more licensed professionals into the home is, I think, a great idea. There has been some data looking at actually doing hospitalizations at home so that you have physicians and nurses going together into homes to help change, minimize the need for people having to be in the acute care setting. The problem I just want to again address that some people who are living in SROs or some people who don't have adequate spaces for what we could call a home. They have a structure that they live in, but they're not, they're not necessarily healthy homes. That's just something for us to raise in our consciousness, that while I think it's a good idea to move more services into the home space, that we also need to make sure that those homes are safe.
Thanks, Rupa. I think it's a very important point, and one thing that I think about is the largest growth in our homeless population in California is individuals over the age of 50. So the notion that the housing component for home and community-based services has to be front and center, I think, is a really important flag. Thank you. Sarah, and then Don, your hand came down. Not sure if that.
I'm happy to add if there's time, and I can.
Yeah, no, we're going to make time. Sarah, why don't you go, and then Don, you can close us up.
Okay, so I just have quickly, I think this is a great discussion, and it's critical to have LTSS as part of a unified financing and single payer system. I actually have a suggestion or a recommendation for a final report. The Milliman appendix looked at the financing of LTSS, but it didn't monetize or take into account that basically that this system is financed by unpaid labor and unpaid labor of families, of women, of people of color. It's regressive. It's basically a regressive tax. And there's not only that it's unpaid and that it's work that's unpaid, but there's also, as I think Commissioner Scheffler said, there's a cost to the economy, to productivity and contributions to the workforce. And so I think it would be really important to contextualize this discussion and the cost of LTSS, as Dr. Pan raised, to be able to really monetize that and have a dollar figure on unpaid labor and the cost to the economy to include in our report. I think it would be incredibly helpful to move the discussion in California and nationally, because everyone, like with the aging population, it's going to be so expensive, and we really need to invest in a better paid workforce and a better trained workforce. But there's such an invisible hit to the economy. I think we need to bring that into the light and put a dollar figure in it and include it in our financing report.
All right, Sarah, thank you for the suggestion. Noted, written down, appreciate it. Don, please.
Great, thanks. So just a couple of comments, and just for background, CalPERS runs a long-term care program that is not small. It's not as very comparatively large as our health program, but there are 115,000 policyholders in the program. We just went through an incredibly painful 52% rate increase this year, and we're looking at a not insignificant rate increase next year as well. So a lot of that is driven by the numbers Dr. Scheffler mentioned, the $100,000 plus costs for institutional care. And as we talk to our members, we hear what everybody here is saying, that people don't want to end their lives to live the last years of their lives in institutions. They want to be in their home. So we've spent the last year developing an alternative benefit design that will be rolling out sometime towards the end of next year. That is an aging in place focused long-term care benefit that we're hoping our policyholders will voluntarily move over, where we invest heavily in front-end support so that people can age in their homes as long as possible with more targeted support so they can do that. And it is a bet that we are making that it's also going to allow us to save money over the long term, because if you think about those $100,000 plus costs for institutional care, that can go a long way in supporting people aging in place. So that's that's important. I applaud what Michelle is doing and what the HCS has been doing over the last few years in this space, and just a general focus on that. The other thing that's really interesting from the CalPERS perspective is that, you know, a number of the folks in our long-term care program, not all of them, but many of them, we also manage their health care. They're CalPERS members on the health side, and it is incredible. These are a lot of folks have talked about the importance of thinking about the health needs, but these are also our most expensive members just as patients. So, you know, the cost for people who are in the latter years of their lives, they tend to, you know, they're living with much higher incidence of chronic disease. They're frail, and they, you know, they live in these environments that are completely cut off from the health environment. So that, you know, on the long-term care side, folks are thinking about delivering long-term care and not thinking about health. And when a health issue arises, they kick them over in a pretty uncoordinated or completely uncoordinated way into the health system. So, you know, that we see this as an opportunity for us on both sides. And I think that speaks to the opportunity in the integrated financing space as well. So just a couple of thoughts.
Thanks, Don. The alternative benefit design sounds interesting. We've talked a lot about alternative benefit designs in sort of our space in the Medicaid and world. So it'd be terrific at some point when it's appropriate to see what that looks like and what you're thinking. Okay, Bob Ross, late hand up. Quick comment, if you will.
Yeah, thanks so much, Mark, for squeezing me in. Jenny, just adding to the kudos and appreciation for your advocacy and remarks. Do you have in back pocket, Jenny, just give us a sense of the projected health labor workforce shortfall for long-term care and aging? Do you have a 5 to 10 year number that gives us a sense of what the scope of the projected workforce issue is going to be?
Well, I'm going to say something, but I don't know that it's going to be anchored with new information. I think in the report on the California Future Health Workforce for the future, even the direct care worker workforce, I think we were going to be shy about 650,000 direct care workers alone. And then we were talking about mental health and primary care. But there is the workforce in programs that serve older adults, such as nursing homes and assisted living. The turnover rate right now, though, you know, there are people working. The turnover rate oftentimes is 75 to 120%. And PHI, which is a national organization that really covers this workforce strongly, is one that probably has the most accurate information that I'm sure we can get. But they really do cover the waterfront on thinking about this direct care workforce, let alone the issue of nurse leaders in nursing homes and all. But there are a few agencies we can triangulate and get some better figures together. But it's big. It's hard enough in acute care. It's worse in chronic care.
But to my colleagues' comments here, Mark, this is a health opportunity, but also an economic development and jobs opportunity as well. So.
Yeah, Bob, we can, to that point, I can ask our team to try to dig up what is in the various reports. Some have been referenced, some haven't on this issue. And I think I don't want to lose sight of what Sarah and Richard Scheffler mentioned in terms of the informal, the family workforce and the cost of that work. And tying it back to the equity and frankly poverty concerns that I know this commission is squarely focused on. So thank you. Obviously a lot more that could be spoken about, Jenny. Thank you for just bringing your wealth of information and experience and frankly the people that benefit from the work and sharing their voice and to the commission, I think loud and clear, central piece to what we do and what we put in the report and the question is how we articulate the next steps that follow up here. Sarah, your suggestion, I think a number of other things that I think about hearing the conversation. So appreciate being able to dig in. And as with all things in this commission, we have to wrap up and move on to other things before we're totally done. But if you will join me and kind of go into the next part of our conversation around transitions. So let's, this entire commission, we have been thinking about where we want to go, but I know all of you have had an eye around transitions, and it's come up in a number of different meetings around challenges, opportunities, barriers, even for some people. They think that both it's the administrative or the sort of actual boots on the ground transitions, operational transitions. There's the emotional transition that people are going to have to struggle with and deal with. And so there's a lot in this space. And I wanted to take the next 2 hours roughly to engage the commission on how we think about some of those transitions. And I've, we've talked a bunch about why we all came together to focus on the priorities and principles emerging, evolving throughout this pandemic, really. Had this commission come at a different time, we might have had a very different experience with where we want to go. And I commend all of you for talking about sort of that new place that we're trying to arrive to. And today is about the bridges that are going to help us get there. How many bridges, what those bridges have in terms of their load capacity, how long they are there any sort of rest stops along the way? And so I want us to think deeply on this next question: what steps would exert the greatest leverage in making an effective transition to unified financing, both on the financing side, but then also a number of the other areas that we've talked about, whether it's on the workforce areas, on some of the data and IT platforms that are going to be needed, what the role of current players is today and how it changes down the road. So I've invited 3 people, as we often do, to share some more specific thoughts, probably over the next 30 minutes. I've asked Carmen, I've asked Anthony, and I've asked Bill to share a little bit about this issue around transitions. Each has been asked to focus a little bit more on a specific area of the conversation. For Carmen, the question around how we transition some of the financing and how we pay, this important conversation that I think we've had with a lot of coalescence on the role of plans. You heard me say last time that just what the role of plans in the future is an open question, but one that no doubt is one that needs transformation. So Carmen, I invite you to make a handful of minutes of points around those issues and other areas. Anthony, you as somebody who's been through many new program additions to the California health landscape, the ACA, and millions of people earning coverage and being on-ramped, if you will, into existing programs that were themselves under transformation. What are the lessons we have learned? What are the lessons that we can take away from those moments of transition for real Californians who've either been engaged for the first time or experienced some change in the health system that they experienced? And then lastly, I'm going to ask Bill to round us out with sharing 6 to 7, I can't remember if it's 6 or 7, of what he calls building blocks. In my conversations with Bill, he's mentioned a handful, these number of things that really a state or a nation needs to consider doing and putting in place to really be prepared to move to a unified financed health system. So without further belaboring the issues, I'm going to turn it over first to you, Carmen, if you can. Can we go to the next slide? I want to make sure I didn't miss anything else. Oh, before I go to you, Carmen, let me just say, because this was in our slide deck, that there's a lot that we have to decide on design decisions. We've gone through many of them, and obviously the timeline of these will help set and think about the transition priorities. And then I also want to acknowledge that many things that we've highlighted throughout the meetings that are important features or building blocks of this transition are things that are already underway. We've done a lot and continue to work on claims data, the collection of that data, the sharing, the transparency around that information, financial reporting. There are efforts, we've talked a little bit about them around workforce, but in the face of what we just talked about on LTSS and other areas, certainly not enough. There's been other foundational investments that have been made that I think get us directionally moving. But I just don't want to lose sight of some of those that live within the agency I have the privilege of running, but in other parts of state government and local and private sector as well. Next slide. Okay, so before we get into our discussion, I'll invite Carmen to take the floor for a little bit. Thanks, Carmen.
Thanks, Secretary Galley. Thinking about the questions that you gave me in advance, I really wanted to kind of try to set the stage for our discussion. I want to make sure that we don't lose sight of our goal here, which is to achieve high quality healthcare for all Californians. So when we're talking about transition, I want us to prioritize the needs of patients and patient care in the front of our minds. Of course, we should expect that it'll be an all hands on deck situation to transition. Providers, state government, advocates, policy experts will all have to put in the hard work to transition existing agency structures and regulatory systems where we can, and to get new processes up and running. But I think at the end of the day, any temporary inconveniences to providers, agencies, regulators, this is ultimately an acceptable price to pay for us to end the pain and suffering of patients that is caused by our current fragmented system of insurance. Of course, there's complexity to transitioning a huge portion of our economy from a system that's fixated on market principles of profit making to a system that prioritizes care and meeting the needs of all patients. I think we all fully appreciate that change on this scale can be daunting, but as a kind of rallying call for all of us in the commission and for those of us in state government that will be working on our transition, and I think philosophers certainly have said this better than I could ever, but we should not be afraid of challenging and changing the status quo. Rather, what we should be worried about is what will happen to our patients and to California's health if the status quo is maintained even for one more additional day. We know what will happen if we don't change, or if there's a long transition. Healthcare costs will continue to rise. Health insurers, employers, corporations, healthcare corporations, they'll find ways to increasingly pass on the cost to patients regardless of whether or not it kills us. Patients will continue to avoid care because they can't afford it until it's too late. People will be falling into medical debt. People will continue to suffer. The cost of delaying a transition are high and would be paid with people's health and lives. So, with that said, some quick points here before getting to the questions that Mark sent me earlier. We should ensure that we meaningfully engage the public on transitioning to unified financing. I've heard from a lot of folks that wanted and have wanted to share comments at commission meetings, but our public comment periods are far too short. So I think, what we need is a process for public input in the transition. We can start perhaps here in the commission. We could dedicate at least, I know we've had a lot of meetings, but maybe we could have one that's just for people to comment on our draft proposal. One that's not during business hours. And, second, as Mark mentioned earlier, we have an opportunity to help the legislature here with their transition questions, with Assembly Member Kalra's letter with 16 of his colleagues in the Senate and Assembly. They're asking for our help to get a financing plan on the table so that we can help the legislature discuss this key component to transition. And finally, before I get to the questions, and I've talked about this before, we should ensure that any transition is a just transition for workers in the Health Insurance Administration. We can ensure that these workers receive preferential hiring in the new system. It'll help us get the system going up and running quicker. We need to ensure that they get wage replacement, job training, job placement, retirement benefits, education supports, all of these things. And the consultant's economic modeling shows that we can fund a just transition and achieve cost savings. Now, on the specific questions about transitioning payment systems, I think it bears repeating that we shouldn't fall into this false dichotomy between fee-for-service and capitation. I've said this many times before, single payer proposals including AB 1400 have a healthy mix of payment options for providers, global budgeting for hospitals and other institutional providers, bulk drug price negotiations, and then there's an option for salaries for doctors and doctor groups. In addition to fee for service, if all things go as we might think, doctors may just opt for salaries and not want to do fee for service at all. So on a procedural level, on transitioning to salaried payments for doctors, the answer is really quite simple. That doctors and doctor groups would negotiate and enter into a contract with the system. Agreeing to negotiated salary based on the kinds of services they perform. The salary structure we could use, and doctor groups sometimes already use them themselves, existing salary structures as a starting point for negotiations with the system. And then we could do regularly negotiated steps, step systems for salaries so that they're appropriately adjusted for inflation, years of practice. Different specialties could have different base salaries, regional cost of living adjustments, differentials for folks who practice in medically underserved areas. And with respect to ensuring that doctors are accountable in a salaried reimbursement structures, there's a couple things we could do. We could have doctor groups provide annual budgets, report billable hours, or the system could require that doctors see a minimum number of patients. There could be prorated salaries if doctor hours or the number of patients fall below a certain range. All of these could be built into conditions of participation, where there are reporting on services provided, perhaps monthly, semi-annually, to keep track of services. It's not like doctors aren't doing this already to maintain their practice. So, all of this is to say that, collecting this information, the system can perform audits to ensure that doctors are not either under providing services or over providing services relative to their peers. And to answer the larger question, I think different doctors and specialties are the best situated to tease out and negotiate a fair and reasonable salary structure, a fair and reasonable reimbursement structure. And this work could start before a system is fully implemented. I think a very, very practical approach could be that these negotiations start after legislation is passed, establishing a new system, but while the state is applying for federal waivers. Substantively related to the questions about, how care management happens if we transition away from capitation, I want to remind us, we shouldn't assume that capitation really results in care coordination and quality improvement now. I've said this before, these kinds of payment structures, doctors, doctor groups, ACOs, integrated healthcare systems, they're all structured so that there is some consideration of the financial bottom lines when managing care. So these care plan administrators, some of whom haven't assessed patients, some of whom aren't healthcare professionals, some who increasingly manage care through algorithms and AI, these administrators have a fiduciary duty to the financial interests of health plans, doctor groups, ACOs, healthcare corporations. It's their job to reduce financial risk. And there's a fundamental conflict that we're moving away from by going to direct payments, by ending capitation, by moving away from managed care. You know, there's a reason why in California we ban the corporate practice of medicine. It's a conflict between financial business interests and the practice of medicine. Decisions on care should be made by an individual patient's licensed healthcare professional who has been assessing that individual, consulting with that individual, not Byzantine claims adjustment systems of health plans or algorithmic profiling. This is why the transition is really important to a system that prioritizes patient care. And all of this is to say that the care management functions that happen today inure to the benefit of corporate financial interests, not to patients. So what we want to do under a system without risk-based payments is to place care coordination in the hands of direct care professionals without burdening their decisions on care with financial risks. We can pay doctors for care management consultations with patients, or any time that they engage in care coordination with other members of your healthcare team. If they pick up the phone and talk to your if a PCP talks to your specialist, if they go on a Zoom call with the nurses and doctors in your team. There are a lot of options that we can toy with here that don't involve risk-based payments. And then, you know, I think what's important here, moving away from complex multiple health plans and risk-based payments schemes helps doctors and nurses and other healthcare providers. You know, health plans today, even in the managed care model, are changing reimbursement requirements constantly. And what we're doing is we're asking doctors to transition one last time from a complex multi-payer system into a simplified payment system with one plan, one standard of care, which brings me to the oversight question on transition. We don't have to recreate the regulatory oversight wheel here. We could transition the DMHC or OSHPOD to fill some of these auditing and data collection and oversight roles, like doing independent medical reviews. And the major difference for the DMHC, of course, would be that instead of monitoring, I think I looked it up, 120 odd plans. Instead of all of those plans, they'd have one plan to monitor and one plan to regulate. And OSHPOD could have standardized reporting requirements through uniform conditions of participation, uniform billing practices. Auditing misuse and abusive practices becomes much, much easier. And, you know, we'd have greater transparency, and the system could monitor better for coding practices and utilization that are potentially abusive, upcoding, or identifying potentially concerning outlier practices. These all become easier. And I think, you know, we have systems in place that we can shift to. And then really quickly on the timeline question, I said this earlier, you know, we need to transition as quickly as possible. The longer health plans are allowed to maintain a role in our healthcare system, the more opportunities they have to take advantage of us in the interim, to hike up premiums, to lemon drop the sickest, and then push them onto any public system. We need to move people quickly onto a unified financing system, importantly, because that is how we achieve cost-saving benefits. In order to capture savings, it's imperative that any single payer system, any unified financing system enrolls as many people in into the system at once, so that we can have the negotiating leverage to get fair and lower prices and to end administrative waste. You know, we've done it before. Medicare took 1 year to implement in Taiwan. Once legislation was passed, their program implemented, they had 90% of their population enrolled in 10 or 11 months. There's no reason we can't do that here. Again, once a legislation is passed in California, a governance body in place, we can start establishing the necessary regulatory and governance structures while we are applying for federal waivers. And we can start the payment negotiation processes with providers and start getting providers to enter into agreements with the system. We need to push ourselves to walk and chew gum here. Lastly, just to reiterate, we cannot forget why we've been tasked with planning this transition. There's a real crisis of people suffering because they can't get the healthcare they need. There are working families whose health cannot afford to wait for a slow phase-in, for a slow transition, for pit stops. We can't do that. The longer we wait to fully implement a unified financing system, the more people will suffer needlessly, and we need to remember that. And I'll stop there. Thanks.
Thanks, Carmen. You used your time wisely. You got in all the answers to the questions I offered and plenty more. Thanks.
You asked a lot of questions.
I did. Fair enough. Fair enough. We want your expertise and experience reflected. So I'm going to get through all three of our commissioners who I've asked to speak, and then we can come back to some of what Carmen said. Anthony, please jump in.
Yeah, thank you, Secretary Galley, and thank you, Carmen, as well, for your thoughts. I think similarly, I come to this conversation, starting out being a supporter of single payer. My organization has been one for 35 years, and then the question is just how do you get to a single payer system, which is certainly preferred from our fragmented patchwork of market failures and misaligned incentives. And how do we, but I think that this conversation is different than the sort of the political question of how we get there and how do we pass something, but like, how do we actually do it? The nuts and bolts of how do we get to that goal of universality, of quality, affordability, of efficiency, equity, and simplicity. And simplicity is one of the sort of touchstones of one of the things that really is attractive about a universal system with unified financing. And as has been noted, even though that's the goal, the transition from simplicity to complexity is inherently complex. And again, I agree with Carmen that should not be an excuse to not act. We just need to acknowledge that so that we are fully clear-eyed about what the challenge is and then how we deal with that. And I want to just be very clear that I think one of the things, along with the urgency that I share with some of my other commissioners, is also just the real belief that we need to have and keep and earn the public's trust in this process. That this is we are dealing with their healthcare, and which is incredibly valuable to them. And so any process, both for political reasons, but also for moral reasons, but also for just to make the process work for practical reasons, we need to always have that in mind in terms of that thoughtful implementation. And so, I would, talk a little bit about some of the experiences with regard to the Affordable Care Act. I do that humbly, recognizing that there is a powerhouse group of commissioners here who have their own sets of experiences with implementation. I'm looking forward to hearing Bill, but there's many of us who will talk. So again, I'm not pretending to offer answers, but to just point out maybe some lessons from the work of implementing the Affordable Care Act, expansions of Medicare, even some of the various stalled efforts at health reform in previous decades that I've been part of, and maybe start having those questions and reflections with regard. One thing that I want to point out is just that we recognize that I agree that the sooner we can offer tangible benefits to the public, the better. The sooner we offer that, the harder it is to take it away. That was maybe one of the lessons of the Affordable Care Act fights of the last several years. And so how do we do that. The ACA had this thing where we had some initial benefits, but there was a 4-year waiting period, and that was a perilous time. I think, but I think that there is I want to acknowledge that there is a tension between that and that real goal, and needing the time and to set up systems and to make sure that we're ready to have a smooth launch. And I think that that's that we should just acknowledge that there is some of that tension there. One of the ways to resolve that tension potentially is to use existing systems and existing infrastructure to make it easier to get going and to maybe provide some security and familiarity for patients and providers. But using existing systems also means that we may be inheriting their existing problems and their existing things that we're trying to actually move away from. And so then that's another tension that we're trying to address. I think parts of the Affordable Care Act maybe have a clunkier design because it was trying to keep certain existing systems and efforts in place. And that's a choice. And there was reasons for that, but it also then brought some problems with it. I think so. I think that that's another tension. And then, of course, new system, but starting from scratch or starting with new systems and transformation can actually get us quicker to the goals of not just a unified system, but a unified system with all the transformation that we hope and want that comes with that change. But it also means that it's a much bigger lift and much more fraught with the potential for startup problems, both the issues of ideological and industry attacks, and also just the more natural things of whenever you make any switch from the status quo, just getting things done in that regard. I will also just say that I've mentioned this, that we should acknowledge that if there was a passage of this by bill or ballot measure or whatever, that the political conversation will not end there. The book about the implementation of the Affordable Care Act is literally called The 10-Year War. And we should just acknowledge that we need a system that will need to be resilient to those types of issues, whether it's court battles, whether it's fights with the federal government, whether it's both efforts to sabotage from different areas, even if we have, hopefully we have a bigger and greater consensus and support. But just acknowledge that's been our experience, that in fact the ACA and frankly even Medicare continues to be a contested space in our landscape. Another area of question or just to raise is just an issue of how do we deal with California's scale, and can all the different issues in different regions be resolved on the same timetable? It's a really different issue about what we would need to do in Los Angeles versus what we need to do in the rural north with just a very different set of providers and systems in place. And should the implementation be driven by a set timetable or by some criteria or go no go list? And should that be variable by region, or is the do we want to have it all start on one day? One small note: I also think that we in government tend to have a predilection of starting things on January 1st. And I do think that we should maybe figure out if maybe the holidays is not the best time to launch big new programs when people have been out of the office for a bit. So small thing. I also want to acknowledge that if single payer or unified financing was passed, I appreciate the acknowledgement that there will be necessarily some stages as we maybe have financing set up or seek federal approvals. And I do think that there's a lot that we could potentially do in that period of waiting for federal approvals to get going. Because whether it is, I know there's been some discussion on this commission about what those approvals would take, but whether it's congressional action or whether it's court challenges or whether it's whatever, there would be some times there that we should not waste. We should try to urgently see what can we have as much rolled out as possible, and maybe that's by program. If the Medicare waiver is the hardest to get, should we start with the non-Medicare population, or with benefits like dental or long-term care or other pieces that we would not need the Medicare waiver for, right? Like, just how do we get benefits to people as quickly as possible? And I think there's and we should just think creatively about that. And frankly, I guess I want to say that in the context of the report that we're coming out with, I think it would be great if we can really detail out not just the decision points that we need to make. If we're deciding we're doing unified financing, deciding or at least teasing out the details of this, but really detail out what that to-do list, what that punch list looks like. And then maybe even categorize what can be moved to be done as soon as possible. Do we need to set up universal provider directory and have initial contacts and communications? That's something that frankly we need already, but and that has been set up. But how can we do that as part of the first things in a first phase, even while we're waiting, even if we're waiting for federal approvals, for example? How do we move to global budgets and all payer rate settings? Now, typically we would want to do this with the power and authority of a single payer purchasing entity, but there are existing authorities that we can move in this direction as a prelude to a unified financing system. And I think that time would be really important to lessen the very significant variations we have between regions and between providers with regard to what we pay. Having that system dealing with that disparity is going to be a big challenge for a single payer system of changing overnight. If there was some period of time that would help in doing that, and that might involve both having some look at those who are on the upper end of those payment variations, as well as helping beef up or improve those that are on the lower end, especially those maybe in public programs where reimbursement rates need to be adjusted upwards. Can we get everybody a card that has attach it to their medical records? Again, have that universal card distributed that has their attachment to their medical records. It connects them with the coverage, and so that we have the infrastructure in place to do a final transition, and then just all the other work to standardize contracts, standardize medical codes. Do the sort of it's some of it's nitty gritty, but some of it's really important to get to make this process a success at the end of the day. And I think we've talked a lot in this area about workforce, and not just to scale up, but also to just to begin the work of changing our mix and of the workforce that we want a more rational system to be, and that means both up, but also having adjusting to the fact that we will want more primary care, we will want doctors, we will want more of the full range of care that we want to provide. We don't want to just have a unified finance system, but replicate the exact same provider structures. We want to start moving in that direction. So I just want to make I think that these are things that I think a report can detail and can maybe categorize and can maybe sequence. And I also believe that sequencing can actually happen as soon as possible, right? That as Dr. Galley mentioned, we're already working on some of these elements already. whether it's the health information exchange, whether it's the work of Covered California in standardizing benefits and medical necessity, also the Department of Managed Healthcare, whether it's getting the uninsured and more systems of care and coverage, which is really important because we know that when uninsured folks get into the healthcare system, there's like a 2-year bump in their utilization as they deal with untapped needs, unmet needs, before then they sort of cycle back into a more a regular pattern of using care with the rest of it. So let's do that as much as possible. And again, what I'm discussing here is not incrementalism, but sequentialism, doing what we need to do anyway as soon as possible. Universal standards, building infrastructure and systems, and then I think that's complementary and concurrent with the urgent work of seeing what we could getting done, financing, federal approvals, those kinds of things. So let me pause there because I do want to hear from my colleagues who also have their own lessons that they've learned from these experiences of trying to implement. But I do think that the more that I think that I hope that the report that we have is I'm feeling positive about the fact that it's detailing the benefits of a unified financing universal healthcare system and sort of detailing out what that vision looks like. And I hope that it will be as robust as possible about also showing us the path there as well. Thanks.
Yeah, thanks, Anthony. And just sort of Carmen and you both have made some suggestions on how the report is structured and what it sort of tries to do. And absolutely, I think points you both brought up are our intent. And I hope as you see the outline and the final product that is reflected in it. But I like the way you bucketed some of your comments, both you and Carmen, on this point. Okay, as usual, I can always do better at kind of keeping us cabins so we get more time for a broader conversation. But I want to turn to Bill to share some of the building blocks that you shared with me earlier, to share that with the whole commission. And then we'll move into sort of time for people to ask questions and respond, but also add their own thoughts on the transition piece. So Bill, please go ahead.
Thanks, Mark, for give me a few minutes to talk about the building blocks. And I appreciate the comments that Carmen and Anthony just made. I think all of us are clear the goal of the unified financing is to give equitable, affordable, and high quality of healthcare to improve the health of the Californians. But also the system has to be sustainable. And so Mark, you talk about building bridges. And so I'm going to offer you what I call the foundations that you need, the pillars you need to build the bridges, going from one place to another place. Where we want to go is unified financing, but we're starting where we are. And this building blocks I'm talking about is based on international experience, as well as what Vermont had to do after we offered our proposal and then they passed legislation to implement it. So I like to quote the former President John Adams, who gave a dictum: facts are stubborn things. So what are the facts that you have to put in place to build these bridges? I'd like to list 7 of them quickly. First of all, if you want the system to be affordable and sustainable, the state needs to set a prospective global health expenditure target. What that does is close the checkbook. Right now, we have an open checkbook for health plans and the 2 providers. That's why our healthcare costs rises so fast, as well as we are spending the most among all the advanced nations. Massachusetts has led the way to close that checkbook. And I know California is actually thinking seriously about it. So that's number one building block you have to put in place. And I'm glad California is moving for that direction. Second, we have to address the inadequate supply in the underserved areas. Otherwise, you see, when you put in unified financing, it's like you create a new dam. And you open up the dam, unless the irrigation channels are built. Otherwise, that water just going to flood some areas or waste it. So we have to actually put in that building block to put in adequate services in underserved area, particularly, let's say, in the rural and central California. And for example, my own opinion is you need to build community centers. You have to attract people there to employ them. So that's the second building block, is build up the supply side for the underserved areas before you open up that dam of money. Third one is developing the appropriate workforce. Carmen and Anthony already elaborated on that. I will not take more time to say, but training, even with continuing education for the existing practitioners, so they can be culturally sensitive to the patients they are treating and caring for. That takes a long time. That's why you have to put that pillar in early before you really start. And the fourth one is what Carmen talked about, negotiation. Negotiations can come to a better solution and reach a consensus when there is a fact for both sides to base their arguments and their positions on. California already had required the hospital to report their costs down to the cost centers, but it doesn't get down to the every service or procedure. I don't understand why that was not done, but you need cost accounting certified by certified public accountants that hospitals actually identify their actual cost for each major services they deliver. Then you can actually have the fact, what is the actual cost? Which hospitals is maybe inefficient? Which ones are more efficient? Now, what's the appropriate price or capitation or fee for service you're going to pay to these hospitals? California can move that just through executive order. And I would say there are other examples I can give you what facts California can just do it through executive action with some budget support to build up that I call factual base for negotiation, for decision making. Then the fifth one is California needs to develop and establish a purchaser alliance. Right now, Medicaid, Medi-Cal negotiate. Medicare dictates by federal rules. Every health plan actually gives some their own. I would urge you to form a purchase alliance, then first negotiate with the drug pharmaceutical industry for prices, lower drug prices. Use that experience, then develop a whole process in the institution as how you're going to negotiate with other providers. And this goes into what Carmen said earlier. That whole procedure and process, as well as the institutional arrangement, is key in building up an efficient and affordable health care that can sustain the universal financing. Now, let me move quickly to two others. One is to develop a uniform clinical record system. California is already thinking of doing that, but that should move with all full speed. Technology is already there. You can actually improve the quality of care for all the Californians, as well as save money through removing duplications and duplication of tests, duplication of visits, duplication or inappropriate duplication of drugs. You only have to look at what Kaiser does through a uniform clinical care system, how they are able to actually improve quality as well as save expenditures. This is an experience of Taiwan, Germany, Canada. And the last but not least is develop a uniform data system for claim payments. You need that uniform data system to monitor what each major providers and doctors are doing. Then you are able to you can prevent fraud and abuse in claims. That could save 8% or more of the health expenditures with what I wrote before. And that will make the uniform financing more affordable, and that people are going to say, okay, this is a system that's much better, but actually will not cost me more money. For me, that's a major selling point of your single payer system. How do you take advantage of that? And then you need this building block of unified, uniform clinical record system and uniform claim record system. Those things could take 2-3 years to develop. And I will urge our commission, consider these building blocks and move them as soon as possible through executive action, allocate some budgets, and some of it will require legislation. But they can be then separate legislation, because regardless what kind of single payer or unified system California has, these building blocks will enable you to have a much more affordable system and sustainable system. Thank you.
Bill, terrific. Thank you for summarizing a lot of content very quickly. I think it's great to have your expertise and experience. To Carmen, Anthony, Bill, thank you for always stepping up and taking a little bit more of the question and comment time to share the thoughts that I know you guys have been working on for a while. I want to, before we open it up, and I of course, if we get a little slowed down, I don't anticipate that's going to happen with this conversation. I'll pull a few of you in, but I think I'm going to open it up. But before, Richard Scheffler, your hand came up first, and then Sandra, and please raise your hand if you want to jump in here. Just want to remind you that for this, love to hear comments to Carmen, Anthony, Bill's points that they made, but also ask you what steps would exert the greatest leverage, right? So we're talking about how do we sort of catapult us forward fastest, soonest, with some key actions around transition. So I'd love to hear either an endorsement of something you've already heard or a new idea or something that we haven't raised today that we've brought up before that you think is germane to this conversation of transition. So Richard Scheffler, please go ahead.
Well, thank you, Mark. I'm going to build on some of the comments that Bill made and the other commissioners as well. I have my own 6-point plan. Why not? So whenever you make a transition, as I taught this in the public policy school, from one type of public policy to another, we teach our students the obvious, that there are winners and losers for every change. So the first thing I would have the commission do is identify who is going to be better off and who is going to be worse off, looking at the providers and the patients and other actors in the healthcare system. And in that look, I would pay particular attention to the equity issue. What are the equity issues that come about when we make this transition that we want to deal with immediately and forcefully, and view the transition through the eyes of health equity and an opportunity to improve it. Secondly, I'm all in with Bill. You wouldn't be surprised that you have to have a sustainable system. So there's no doubt that some kind of budgeting, cost control mechanism is important. And putting it in place is going to be exceedingly difficult. We do, of course, have a proposal for an Office of Healthcare Affordability. I'm hoping that this year we have more success passing that legislation. But just imagine what you're trying to do now. You've got California, the 5th largest economy in the world. And then you've got its healthcare system alone, just its healthcare system alone, which is bigger than the budget. There's only 25 countries, or more or less, 26 to be exact, whose total budget, including countries like Ireland, is the size of the healthcare budget in California, just to give you an idea of the scale. The enormity of the money that we would be moving around is going to cause tremendous shocks in the system, dealing with employment, with opportunities, with benefits that people have. And it's just an enormous job. It's not to be taken lightly, just because of the size of the budget and the amount of money that we're going to be impacting on. But you can't ignore it. And there's going to have to be some forceful actions thinking about how we're going to do this. And you got to get started. I didn't hear a period for this transition, by the way, Mark. Was it 5 years, 10 years, or 50 years? But I assume you mean 3 to 5. it would take to me something like that to really transition the enormous size of the healthcare system in California to what the commission wants it to be. As I've talked before, I'm in favor, and I think other commissioners are, to taking what I think is the secret sauce of the healthcare system in California, and that's its large integrated delivery system, which has produced very well for the state. The average spending in California per capita has been lower than the per capita spending in the United States for many, many years. And much of this is attributed to that integrated delivery system. And well, we can do better, and we need to think about what the next generation, what is the new integrated delivery system? What can we reimagine that system to be? We're not satisfied with the current one that has lots of good things, but that has many things that need improvement. The commission should weigh in on this and start to develop policies and legislations to improve this delivery system, including the payment system. We want to pay for value. We just don't want to pay for care. We want to pay for value, which means we want to pay for high quality care. How do you do that? And how do you develop that in the new healthcare delivery system for California? We need to take steps to do that. It's not going to happen by itself. It's an important component of what we need to do. And to sustain it, we need a tax plan, or we need to pass it. And so for me, I think the legislature has told us and you and me and everybody a number of times, don't send us a plan that you can't finance. So for them, job one is they want to see the financial plan. They want to see where the money is coming from and how we're going to get there. So that has to be in the initial phase, because if not, we'll disappoint the legislature, and I'm afraid all of our work will end up on some shelf somewhere, and we certainly don't want to do that. I'm totally all in on the workforce. I've written on it many years, various books I can send you and articles, but we need a new workforce that fits the new delivery system that we have in mind. And those two things go together. You can't have a workforce and train it unless you know what you're training it for. And we want to train it for the new healthcare delivery system in California, which to me uses integrated plans. And how is that going to work, and who are they going to be? And then I think the commission just is going to have to take straight on. The issue is, what is the role of the state, in this case, California, and what's the role of the private sector? And is it one or the other, or a combination of both? And I think we've danced around that question a lot. The report has to, I think, confront it. And it's a very different kettle of tea in the transition if we're thinking of this being a state-run healthcare delivery system. Not only financed by the state, that's what we're talking about, unified financing, but do we want it run by the state? Or do we want some of it run by the state, as we have now, and some of it run by the private sector? Is there a mix that we're comfortable with? Who should do what? And to me, you can't make any move on this without confronting this question. So in sum, that's my high-level 6-point plan to think about. I realize that some of this would go, of course, Mark, in the larger report. And of course, and that's all good, but I think until you have this vision, you really can't write the larger report, and you can't really work on a transition, though it's good to have the conversation unless you know what you're transitioning to. So this is the old chicken and egg problem that we have. So I'll stop there and look forward to the comments of my other commissioners and colleagues.
Thanks, Richard. Let me just make one comment to this last point that you've made. I think that the report is certainly going to capture many. The hope is, and this is being informed by today's conversation, sort of the building blocks, the next steps, what do we do immediately? How does the sequence look? I think all very important. I would say that the commission has done a lot to articulate and create a vision, a destination, a place to get to that I don't want to lose. I don't think that that is completed, but I do think a lot of it has sort of been established, and there's a lot to talk about how you transition to those things. Maybe it's not the entire island or place that the bridges get built to, but I think that there's been a lot that has been done. So I only offer that as a comment because I do hope that the final report has some things that really drive to levels of completion, wherein in some other areas, maybe it can't be as deeply done because of some of the gaps in decision or clear articulation on some of the issues you brought up. So just to really kind of help frame what I hope will be a report that does go pretty far in some really important areas. And I think that comes on the back of the work that all of you have done in a tremendous way over the last many months. So I'll just offer that as a point and really appreciate your pushing to say, hey, what is the timeline on the transition? Is it 50 years or is it 5 years or 3 years? I think an important part of kind of goes along with Anthony's whole sequencing comment and a little bit about Carmen's comment of walking and chewing gum or doing things in parallel as well. So I think all of that comes together pretty nicely. And just I promise you, I won't offer you a report with a 50-year transition plan. Please don't. Let's stop that talk now. All right, Sandra, please jump in.
Yeah, thank you, Mark and Carmen, Anthony, Bill, Richard. Appreciate all those comments. Mark, I was reflecting on your question that you posed in particular to Anthony, and it made me think that it might be worthwhile for the commission to look at what we did with Healthy San Francisco. I'll just remind folks that when our now governor was then mayor, he asked us to convene a group to answer the question, how could you get everybody meaningfully into the delivery system? And I don't want to recap the whole thing here now, Mark, but I do think there are some important lessons that might be learned from looking at, if nothing else, the evaluation of how we went about implementing Healthy San Francisco. I'll just name 3 or 4 quick things because I think they're relevant to what we have been talking about and certainly relevant to our North Star. As a process matter, labor was at the table, the chamber was at the table, small business was at the table, hospital CEOs were at the table, FQHCs were at the table, and importantly, consumers were. And so what we ultimately designed had really virtually all of the stakeholders, except for plans, because it was never meant to be run by insurance companies per se. So plans weren't there. It was, of course, a very data-driven process. And in fact, many of our health plans offered us pro bono work on actuarial data. And it was a very comprehensive set of benefits. Caveat, and in hindsight, we did not include oral health. And if I had to do it again, would, to extract the mouth from the rest of the body, not very helpful, but it did certainly include behavioral health. And at the end of the day, it included employer contributions. which actually did get legally challenged. And actually the courts found for the way it was ultimately financed. It was an incredible and remains, I think, a very popular program. And so to Anthony's point, getting some early wins on popularity of the program and ease of use, administrative simplicity, was super important to get early momentum. And then the last thing I would say about it is we did choose to leverage an existing not-for-profit entity to implement it. In that case, it was San Francisco Health Plan, a nonprofit Medi-Cal plan. And we used them to do marketing and enrollment and an assignment to primary care medical homes and the like. So we didn't create a new structure to do this. We sort of said, what's available to us to be able to do this? Now, certainly not at the scale of California, to Richard and Bill's point, but I think a lot of important lessons about how you stand up a program without health plans in this particular instance, and how do you leverage and govern it and finance it in a way that was sustainable and is sustainable. So I don't want to go through the whole thing. It's not all applicable, Mark, but there's a lot that's been written about it that I think might be useful. And so some little homework on that might be worthwhile. And then one final point on workforce, which everybody's mentioned, and I agree with all the comments that have been made. I'll just note that the Workforce Commission report with recommendations that we did several years ago, CHCF has commissioned an update to see how our progress to date against those recommendations is going. And that report should be available, I'm guessing, in the next 45 days or so, and I'll check on that, Mark. Keep in mind that will tell us about the roadmap for our aging workforce, for behavioral health, and for primary care. It is not addressing all of the workforce we need or the different types of positions we need. But I think it was important for us to measure our progress against it, which my hunch is that it's going quite well. We're going to be pretty comprehensive and look both at what the governor and the legislature has done, which is substantial from the public sector side, but also what the private sector has done, which is also substantial. The UC Regents is considering a similar conversation coming up. So I think we have a lot of information on progress on workforce, and of course will help us identify additional gaps. So I don't have a 6-point plan like Richard does, but hopefully helpful remarks.
Definitely helpful, and point taken on Healthy San Francisco. Those of us who were in San Francisco while it was coming about running the health system on the ground really appreciated the way it was done, and I think it will be good to look at that evaluation. And excited, didn't know CHCF was doing an evaluation on the workforce piece. That will be terrific to see where the gaps are versus what we had planned back then, and then maybe leverage it into the opportunity to say, well, what's different? I think Richard's point about you want a workforce to work in the system that you're planning, I think is a really important one. And it's probably evolved a bit since that report, as it will continue to. But thanks, Sandra, for that. Sarah first, and then Richard Pan.
Thank you for incredible presentations, as always. I took pages and pages of notes. It's great. I just wanted to emphasize and build on a couple of things that were said. One from Commissioner Costi about chewing gum and walking. And I think we should be running. I think, even before this report comes out, we should be thinking about what we can put in place to build this foundation that has been laid out, like the building blocks that we need by the commissioners. Like that should just happen. It should be. And I think the report should capture the key areas where that work needs to start happening, whether it's an EO, the budget, legislation, regulatory change. I was also struck by her comment about that we don't need to recreate the wheel of regulatory agencies, and that DMHC might go to having one plan. Like just the capacity that could be unleashed and the opportunities for these agencies to do more things. But one of the problems is that because we have such a fragmented system with huge holes in the data and the transparency, we have a fragmented regulatory system. And a lot of agencies without an actual central agency, really, that's looking at the entire system, especially with creating a sustainable and efficient system. I just wanted to make a plug for the Office of Healthcare Affordability. I think that was what that office was striving to do, was to have a kind of 30,000 foot view of the entire system from health plans, hospitals, providers, and pharma, and gather some of the data that Professor Shao mentioned we really are going to need. And then I would just say endorse the building blocks that Professor Shao put out. But I really was struck by number one, about setting a prospective health expenditure target, because that idea of closing the checkbook, which I love, one, it gives us so much more leverage in negotiation with providers. It gives us something to say like, hey, there's a limit. We are just not going to pour unlimited taxpayer dollars into you walking away with whatever you want. And it also helps with the public to say, this is going to be a responsible and efficient system. We are not going to waste the taxpayer dollars that you're putting in. So I think it's just important on 2 points. And the idea of having all of the facts down to the cost of each service, that granular data that is certified by accountants and accountancy firms. I think that's a discussion we had with the Office of Healthcare Affordability. That is so critical, because if we're going to be going in, even if we have the power of the state, we don't know now the prices that people are paying. And even if we eliminate health plans, it's still dollars flowing from the state to providers in the healthcare system. And so just because it's unified financing doesn't mean that it limits the amount of dollars that are going from the public to the system. And so I think we really need that information and that ability to negotiate so we have a sustainable system. So it was great presentations, really exciting. I'm starting to get excited for this report and what this commission can really put together and start moving in January. So thank you all.
Thanks, Sarah, and I'm glad we're all coalescing, and that feels exciting for many. Good. Richard Pan, please jump in.
No, thank you. And actually, I really appreciate the discussion and thinking about our ACA implementation, having come into the legislature at the time when the ACA essentially was passed and we were implementing it, was involved in actually the establishment of S-chip. I wasn't in California at the time, I was in Massachusetts. Actually, I think, and also, I appreciate Sandra Hernandez talking about San Francisco. I was actually in charge of the Children's Health Initiative here in the Sacramento region. We were the only multi-county Children's Health Initiative, 5 counties that wasn't governed by a single health plan. So there was another multi-county, it was Partnership Health Plan, but they already had an existing health plan that covered the counties that they covered. So they didn't have to set up a whole new infrastructure. We did. So we had to get 5 counties. I would also point out that the counties that we pulled together were not only Sacramento, but Placer, El Dorado, Yuba, and Colusa. And I would make note that even though we have essentially over 2/3 Democrats in both houses and every constitutional office, there are more conservative areas in the state, and and they have, and to a certain degree there has to be a certain level of buy-in as well, and I think COVID is teaching us what happens when there's political division, right? So we can vaccinate everybody in all the blue areas, but if the red areas don't, we're still going to have outbreaks, right? If people are not going to follow along, we're going to still have problems. And so I think when we talk about transitions and so forth, we got to figure out a way to build enough of a consensus that people go along. That's what we had to do with our children's health initiative in the area. I mean, I had both more conservative and more progressive areas. We had very rural areas as well. We had to build networks out there to make it satisfactory, et cetera. Actually, we did include oral health in ours. So we did have vision, dental, and health. Didn't have long-term care, but that was for children. So I guess, we didn't have LTSS part of it. But, certainly it was we learned some very important lessons in making that successful and putting that together. And so, I do appreciate discussion. I do think that some of the things that Scheffler brought out, I think, going to be very important. We're going to have to come up with a mechanism not only for financing, but show we can actually implement it. So, I mean, I get the idea about, and there's certainly some things we can do, not so much because we're looking at unified financing, just because it's better for the healthcare system, things we would do before we get, let's say, a federal waiver or something. But you have to show that you can deliver on that, right? So there has to be at least some degree of certainty we're going to get the federal money, or that the state is willing to raise the revenue that's necessary on its own if the federal government is not going to provide it, or whatever combination that is. Because I think when we had the previous meeting, even with the federal waiver, we still had to raise about $200 billion in state revenue, right, to finance this, and so we have to get buy-in on that. The other part I would also make note is that again, to get the buy-in, just keep in mind, people may not be happy with the healthcare system. There are a lot of people who like the healthcare they got now, right? That's why President Obama, to get the ACA passed, said if you like what you got, you get to keep it, right? I mean, there's a reason he said that. And we know how narrow of a margin it was to actually pass the ACA, and then the challenges of actually implementing it. So, I mean, those are things we're going to have to, realistically deal with, because otherwise we're not going to have the political will to pull this together, right? And so one of the things I guess I would also mention is that it's important to think about why we made the decisions we've made so far in this progressive state already. So, for example, in our Medi-Cal program, which is our single payer, right? It covers 13 million Californians. We are shifting more and more people into managed care plans. Doesn't mean we have to do it that way. Not necessarily for unified financing, but we have to think, why are we doing this? And it didn't matter whether, it's not just because that was when Schwarzenegger was governor. That's under Governor Newsom, right? And Governor Brown, right? So we have to think about why the 40% plus, and it's growing every year, of people who have Medicare choose Medicare Advantage plans in California, right? Those are things we have to take account of, because if we don't, in whatever plan we come up with, I think we're going to have some interesting issues because we can't just ignore that. We need to understand why that's happening and the reasons that are driving that. And if we don't take that into account in our transition and in our final plan, I think a whole bunch of problems will show up, right? There's a reason things have evolved the way they have. Doesn't mean that they have to continue that way, but we need to understand why they're doing it. If we're going to change that direction, what is it that's changed that we're going to change that leads to that change, that change in direction. So and so I think that's really important. And so, for example, we're doing CalAIM, and I'm glad to see Michelle's hand up here. And we're going to ask health plans to do a lot more stuff. And there's reasons why it makes sense to do it that way. There could be other alternatives of ways to do it. So anyway, I think it's an issue about the transition. It's an issue about where we land at the end. But I think it's important to learn to understand history. Let's put it this way. There's that saying that those who don't know the lessons of history tend to repeat its mistakes. So and certainly we've made plenty of mistakes along the way, but we need to understand why we made decisions we made, and what's going to change so that those decisions would be different moving forward in the future. Thank you.
Super valuable comment there. I think a lot obviously to learn. It goes along with Sandra Hernandez's point. Let's take a look and see some of the recent efforts. One thing that many of you have said, I'll highlight before Michelle goes, is that consensus building, making sure the public consumers are there. at the table the entire way has been a theme of successes in the past and can be done here. I think a lot about Richard Scheffler's point about winners and losers, and whether we have to accept this concept of losers, whether we have to rather say, you know, there's all winners and some win a little more than others. Richard's shaking his head, but I think that there's got to be sort of a push on that question and thinking through this notion of winners and losers, because I do think that comes up as a theme in the Vermont story and some of the other stories, how you contend with that issue. So look forward to trying to grapple with that down the road as well. All right, Michelle, go ahead.
As just to follow up on something that Senator Pan mentioned, just what we learned from the seniors and persons with disabilities transition from fee for service to managed care. So people were covered, but there was a transition in that continuity and folks wanting to keep the doctors that they have today. And so thinking through how we transition under a unified financing, what someone has today may not be the provider that they will necessarily have tomorrow. And so just, I think kind of in terms of continuity and transition planning, that's something to keep in mind.
Thanks, Michelle. Jim, glad to see your hand up. Jump in, please.
Thank you. First of all, this has been a really, really interesting conversation, and I appreciate all the presenters and the information that's come forward. As I'm kind of a visual person at times, and so as I look towards a final report, it would be nice, and I'm sure we'll have illustrations. I can't imagine we wouldn't, but actually I could imagine that we wouldn't, but I hope we have illustrations, let's put it that way. It would be really nice to have as a sort of a centerpiece somewhere within the report, kind of a breakdown of what system looks like now. What's the percentage of population on Medicare versus, so that people can have that as a reference. And the reason I bring that up is I start thinking about different populations and how we transition different populations into a new system. We haven't talked about a couple of things here that I'm aware of. If we did, I apologize for missing it. One, ERISA plans. That's 6 million people in California. We have absolutely no jurisdiction over ERISA plans. So is the idea that we'll getting all those folks at the table as part of negotiations and things like that, is that how it's going to play out? But the reality is we don't have jurisdiction over those 6 million lives the way they are insured now. Medicare, if we are not successful, bringing the waiver, what does that mean to the system? What about a system like Kaiser, which is a health plan, a hospital system, and a provider group altogether? Does Kaiser cease to exist under the current system? So that's 20, I think it's 20% of the California population right there under Kaiser. So I think it's important that we kind of outline different groups of people and what, and as we start looking at transitions, what kinds of outreach and things are going to need to be done, because not every consumer of healthcare is the same. And I think that we have to bear those in mind. So thank you.
Thanks, Jim. Really good flags on some key points. And I certainly imagine that the report is going to be able to at least contemplate some of these open questions and challenges and answer some certainly. Okay, let me sort of draw in certain other folks. Can I, John, love to hear a little bit of your thinking on the transitions question, reaction to some of the issues with plans and kind of where CalPERS has been heading to kind of focus on some of the values that we've talked about. Would love to hear a little bit from you, and then following you, if I could put Care on the spot, just hear your reflections on some of this, and then Andy to follow. Don, go ahead.
Yeah, I'm not sure I have a ton to add on the CalPERS side. As someone who worked in the federal government on implementation of the ACA, a lot of what Anthony was saying and many others, and Dr. Pan was saying, all resonate. at the end of the day, you know, let the legislature, or in the case of the ACA, Congress passes a bill. You know, they provide something between little and some guidance on how to implement, and then the executive branch is charged with putting it together. And you know, the ACA, I know that was a very different effort in a lot of ways than what we're talking about here, but it was transformational. I mean, when you think about the role of federal government healthcare pre-ACA and now, it's really different. And there was effectively no insurance function at the federal level. The federal government didn't regulate insurance, states did. And when they created an apparatus to do that, it was brand new. So, you know, I think it's crucial to the point that a lot of people have raised, that you really want to spend some time, you know, Mark, I would recommend going and having lunch with Kathleen Sebelius and talking through, you know, the expected and the unexpected in implementation. But it's, you know, it's worth just getting the lessons. San Francisco, incredibly valuable also. So, you know, that's Anthony is right. I think one of the big takeaways from the ACA is that it's hard to take things back. It wasn't like there wasn't a full frontal attack on the benefits created by the ACA, and the fact that they were beaten back successfully so many times is really important. The federal government was incredibly frustrated by the fact that almost all of the provisions, the main provisions of the ACA, were wildly popular, but the ACA was not wildly popular. You know, it kind of clipped along at somewhere between 40 and just over 50% approval rating nationally, even though when we would poll the individual provisions, they were huge hits. So thinking through that, and just knowing that going into an effort like this, I think is really important. I would not underestimate the importance of thinking about the public reaction, public buy-in, and the way in which this is communicated. And you know, I think Sandra has a lot of lessons in there, because I think San Francisco did a pretty good job. And I think it's really hard to do. People are deeply suspicious and anxious about any kind of change, and when it's their healthcare, it's much more so.
Helpful. Thanks, Don. Kara, can I put you on the spot? See what your reactions, any additions, anything to lift up? There we go. I can't hear you, Kara. Sorry. Okay. While you're doing that, while you're getting back, I'm gonna maybe go to Andy next, and then we can come back, Kara.
Okay, I will be quick. First, I want to change my registration as an incrementalist to a new registration. I'm going to be a pragmatic sequentialist. Thank you, Anthony. I have a couple of reactions to a few of the points. This has been fascinating. I think this is one of the most important parts of the report. So I think one thing I'd suggest is that all the current state agencies that have a potential future role in this can do right away, it doesn't have to take long, is practice more transparency. And I'll just beat on the Medi-Cal program for a second from the standpoint of kids and managed care plans, because I think it dovetails with Richard's point about rethinking integrated care. And in this regard, like, there is a child health dashboard, but it is not plan specific. We don't know which plans are delivering for kids and which ones are not. I think the agency does, I think the plans do, but the public doesn't. Okay, I don't understand why the public can't know that. And I think that there's a chance that if the plans know and the agency knows that the public's going to know who's performing and who's not, everybody's going to up their game. That's just a hypothesis because we don't have a transparent world right now. And you could run that. I'm just picking on the Medi-Cal agency because that's what I do. But I'm sure there are transparency opportunities for other agencies. And that would be a good learning experience. Along the same theme, the drug negotiations, as Bill pointed out, those would be hugely, hugely important to an effective communications campaign on behalf of single payer. If you can drive down the price of prescription drugs in California through negotiation, and you can show people you can do it, that is going to be huge. As you know, the federal government's involved in a congressional debate around that. We'll see how far that gets. But you don't have to wait for that. Okay. Next thing, another point that Bill made that really strikes me as incredibly important to the health equity agenda, unifying the claims forms and having race and ethnicity identifiers on them. That seems to me basic to any kind of analysis of who's delivering what kind of care. I think of it mostly in the context of the managed care plans for Medi-Cal beneficiaries, which kids are getting EPSDT services, which ones are not, are there racial disparities, et cetera, right? Can't tell that without claims forms. So what's going on at the federal level is the 837I, which is the National Institutional Claim Form for Medicare, and the CMS 1500 for practitioners, those have to be reauthorized in 2 years. And there's an effort afoot to try to get, once again, it's failed in the past, but we're trying to get race and ethnicity identifiers on those claims forms. But you should think about the claims form issue in relation to what Medicare might be doing. And then my last point is there's been a lot of conversation about federal waivers. I don't want to relitigate this. The administrative agencies, HHS does not have the ability to turn over Medicaid and Medicare to California. You have to go to Congress to get that. That's it for me.
Thanks, Andy. Kara, let's see if you're back with us, and then I want to pull some others in as well. Rupa, if you want to go right after Kara, and then I'll line a few other people up as well. Kara, go ahead. Okay. I'm gonna, we'll come back. If you want to put any thoughts in the chat, Rupa, if you're ready, please take it away.
Yeah, I just wanted to uplift Richard's comment about the winners and the losers through a health equity framework. So, and also thinking about when, some of these discussions about looking at the historical context of ACA or how these things came on board or what was popular and what was not popular. Those were not happening in the context of a transformational system. And so I just want to put that into that context is important. So if we're talking about creating a whole new system versus trying to cobble together healthcare in a way that won't lower costs necessarily in the same way that a single payer system might. So ACA was hampered by the admission of healthcare industry lobbyists into the negotiations. The public option was just thrown out. So that whole political process, which we should be very aware of in this conversation, is important to remember because there were people and politicians who are really strapped to the healthcare industry, who are being paid by the lobbyists. And that's why I was asking for this commission for everyone to reveal, where their funding was coming from, who's in their camps, so that we understand the inputs that are guiding how we are framing this conversation around the health of the people of California and the opportunities for the people of California. And so that's, the main thing that, the people who are the entities that are going to stand to lose here are going to be private health insurance companies that have a huge grip on how we are able to access healthcare or not access healthcare. The amount of frustration and burnout we experience as healthcare providers because of the private healthcare industry in the United States, but especially here in California, it's causing a real crisis right now in our hospitals. Like there's not enough nurses, there's not enough doctors. So people are leaving the healthcare industry. So this is, I guess I just want to share that this is kind of like a critical moment of us being able to advance something innovative that actually hasn't been done before. This is not the ACA. This is not the same thing, because we have the opportunity to create a whole system that doesn't play by those rules, that starts to envision new rules for how we will move financing in the state of California directly to providers. That's all I wanted to say.
Thanks, Rupa. I'll just, one thing that your comments trigger, and even prior comments, is I think one of the immediate opportunities, at least at the state level, and I think this trickles down to the county level, is do a better job at connecting dots. I mean, our own silos within our agencies, for example, I'm grateful to have Health and Human Services at HHS, but beyond that, seeing the connections between our partners at EPA, Cal EPA, and the connections around climate and some of the movement there, ag partners around food. I think we're doing a lot more with our education partners than we ever have been. I think a lot of the workforce conversation has stopped being about what can, for example, OSHPD or HCI now within HHS do, but along with partners at labor. So this opportunity that over this quote transition period that we're beginning to connect dots way beyond the traditional entities to deal with some of the social drivers of health and other areas that I know, Rupa, you've really had front and center in many of the comments that are directly connected to health equity. So we'll make sure to, as we think about this phase of transition, to make sure that we're doing some dot connecting that we don't traditionally do, or at least highlight. Great. I wanted to maybe ask Bob and or Sandra. Sandra, you and I served together on the Covered California board. Bob, you were there before I was, but both of you've had experiences sort of bringing that body to life over the last decade. We usually have Peter here with us, so I can't pull on him to talk about this, but I don't know if you have any reflections or ideas about where there were moments of transition, lessons learned, cautions, or things to elevate from the work at Covered California that you wanted to raise. I'll maybe call on you first, Sandra, and then ask Bob to jump in.
Yeah, sure, Mark. Bob was certainly there in the early days. So startup, I think he I'm sure has a lot of reflections and observations. You know, I guess I would comment in large part on governance structure, because I think governance will be one of those issues that we'll have to contemplate in this plan. And really building on Andy's comments, which I could not agree with more. Transparency is a super powerful tool. And what I would say is that under Peter's leadership, transparency has been pretty darn good at Covered California, and input by a variety of different stakeholders. I'm not really going to get into the plan aspect of this, but just the principles of transparency as a tool has been incredibly powerful. And if you if you think about Mr. Mibb, where I also served on the board, likewise, an agency that focused a great deal on transparency and public accountability, a vehicle by which this public entity on a regular basis is held to account for finance, for outcomes, for data reporting, for collection of data. And so I think we have, both in Covered California and previously, some good models of the practice of transparency and accountability that has bode California well on some of these programs that we've historically stood up. We talked, I guess, a meeting or two ago about might Medi-Cal look different today if there was a public interface whereby enrollees and consumers once a month had the opportunity to get in front of the administration and really name and call out things that worked well and things that really didn't. And so I would name, in the case of Covered California, sort of this quasi-governmental aspect of it, with a governing board that is, without conflict, however you might want to define that. In the case of Covered California, it's pretty clear how it's defined. And we've had great consumer advocates that have done a lot of the legwork in thinking about how to make the exchange the best exchange we have in the country. And the other thing I would call from Covered California is you can't do anything without marketing. This has been, one of Peter's hallmark messages in every presentation I've ever seen him make. And I think we ought to learn a lot from, whatever you want to call it, marketing, outreach, enthusiasm, really branding a brand new program, which is essentially what Covered California did. So I would call out those pieces of it, Mark. The rules around what you negotiate privately versus what's done publicly is also an area that I think is worthy of study and elucidation for what's good about that and what isn't, because we've talked here, Carmen started, I think, with talking about how do we negotiate and what are the terms and how do you do that, where do you do that? And some of the rules that were put in place for Covered California, really with Bob's leadership on the board originally, I think give us the ability to do good negotiations and yet to have really good information as you went into those and good data as you went into those. So those are some of the high points I would name, Mark, not knowing you were going to call me on this, or I would have thought about it a little bit more thoughtfully. So I'll give it over to Bob, who was there from day one.
As usual, Sandra, even without prep, it was pretty spot on. And I think the call out on the transparency, I've also thought that is what makes partly special Covered California, as well as that public engagement piece. I mean, there isn't a board meeting we hold where some of our friends here on the commission and their teams, but many, many others really, it's sort of tradition makes it sound like it's not as impactful, but it is. I think there isn't a meeting where we don't have really important comments and dialogue, and frankly, they're uplifting things that have already been discussed in other forums, which is, I think, terrific too. Bob, do you want to add anything? I know you were going to transition off camera. I don't see you immediately in front of me, so not sure if you're there. All right, we're gonna come back to Bob if he comes back, or I'll dig it out of him later. All right, Carmen, I see your hand up. Please jump in.
Yeah, I just wanted to speak to a couple of points that were raised a little bit. On the question, I think first, just super technically on Andy's point about federal waivers. I don't think that.
Hello?
Oh, I think Bob's here.
Bob, just give me 1 minute. I'm going to have you jump in after Carmen because she's started, but I'll come back to you. Thanks.
Okay.
And so I think just because I don't think everybody knows this, but Assemblymember Oshkalra actually met with HHS, federal HHS Secretary Becerra's office about a month ago, and the Secretary Becerra's office confirmed that that existing waiver authority is sufficient and that no changes to federal law is necessary, and that they would consider a combined 1332 waiver. So, I think, we at this time have a willing HHS to consider and not change federal statute. And then separately, on the question of this, how do we get public buy-in? I just want to reassure everyone, the single payer movement, if we have a program where we guarantee healthcare for all Californians and get rid of the nickel and diming that healthcare insurers and corporations put us through, we will rally and we will support this program and we will fight to make sure that people support it and that and that we get people enrolled. And there are a lot of people who are desperately wanting to have this change. So I think we shouldn't get confused political will of the public with political will of politicians. I think those are two separate problems. And as an advocate, we have the public buy-in. We've seen the polling numbers, and I think the problem is that we can't get the health insurance industry to pretend like there isn't public support, because there is public support. And I think the last thing that I really think I want to emphasize here is that I think we need to really make sure that when we're talking about transitioning patients from our current system, just because someone's enrolled in a plan, just because we have a lot of people in Kaiser right now, doesn't mean people like it. I'm a full disclosure, I'm a Kaiser member. I don't think they do a good job in managing care. A lot of people don't. And I don't think that we should confuse current enrollment with satisfaction with their health plans. Again, I think that members of the public can really kind of speak to those types of things again. And the people will have our back, I think.
Good, thanks for emphasizing some of that, certainly in the new information about the HHS conversation. Okay, I think let's go back to Bob, and we're getting close to wrap up time. So if you're a commissioner and you want to jump into the conversation in any way, please throw your hand up. Go ahead, Bob.
Yeah, Mark, can you hear me okay?
We can, thanks.
Okay, great. Sorry, I'm going to transit. Boy, a really rich conversation today, and I'm going to be noodling and tons of notes, noodling on much that was heard. Back to the Cover California, I don't have much to add. I think Sandra did, our colleague did a precise focus on how we did it, and a lot of credit goes to Peter Lee. But I think in the early days, what kept us going and forward was a very strong and compelling commitment to a very core set of values and principles, transparency being among them, equity being among them, inclusion and the hearing of community voices and impacted communities. Every single meeting we had, long lines of public comment and testimony. We may not have always heard like what we heard, but we heard it and we took it in. And so that was critical and kept us going forward. And I thought Peter was, would love to hear Peter's 5-step summary on his executive view on that. Just in terms of the application of that to this, I mean, Covered California feels like arithmetic compared to what we're talking about. I think what we're talking about is more advanced calculus in terms of scale and scope. And I'm going to spend a lot of time just thinking as one commissioner about imagining what our deliberations translating into a report and how that report translates into something to the governor, and how the governor describes the legislature describe what it is we're trying to do. And I'm back to a couple of things from Anthony. what I have in my mind's eye, I'd love for us to be able to arm the governor in describing this, to be able to say three things. One, everybody's in. Two, costs are under control and we're responsible and accountable for costs. And three, you can keep your provider. I'm not sure what's going to happen with health plans, so we'll stay away from whether you can keep your health plan. But if we can do those three things, that'll get us through what will inevitably be, no matter our best efforts, be a bumpy transition. And so I'll that's sort of what's going to be in my head. Is my head hits the pillow tonight thinking about this going forward. Just a very rich conversation today, and appreciate your stewardship in getting us engaged.
Thanks, Bob. So I want to wrap up. I sometimes take the liberty of trying to summarize. I think today has been wide-reaching. We've focused squarely on some of these transition issues, but I think certainly this idea that we need to have a timeline, we have to be clear on what some of these steps look like. We need to be clear as much as we can be on the sequencing, being a sequentialist, if you will, as Anthony's coined, or Andy coined for Anthony. I think that certainly we want to be able to talk through some of those steps. I really appreciated where Carmen started. I think that we have a lot to say on where plans are and where they go and how they're imagined, if at all. So that is going to be a very important piece, I think, of our report. I think the engagement and what the forum is going to be to not just enthuse the public, but as Anthony, you pointed out, getting the early wins, the sticky, can't take them away kind of things that might be real game changers for people's not just perception, but hopes and expectation. I think the link, we have a lot to talk about on the workforce piece that we went over today. And I don't want to forget, Jenny, where you started us on making sure we've included that long-term services and support piece in this conversation and within the final report. I appreciate the 7 points and the 6 points and many other pieces that I know we have documented elsewhere that we will certainly make sure show up in the report and in our outlines. And just everyone's comments today, I'll echo by way of wrapping up, and real appreciation to the presenters. It's funny to call them presenters because they come without slides and I ask them to do things in short periods of time, but I'm very grateful to Carmen, Anthony, Bill, and frankly, everyone else who presented in the second part, and Jenny, to you for teeing up the first part of our conversation. So with that, Carmen, I'm always sensitive to how much time we leave for the public. I also just want to acknowledge one thing you said that has always been important, and I appreciated how we did the community engagement piece earlier on in the middle of our process a couple months ago, where we had a chance to engage with voices outside of work hours in other forums with other folks to make sure that we're trying to get into the authentic voices of community. I know that's hard to do sometimes at 1 o'clock on a Thursday, but we are going to try to leave the full 30 minutes that we have left to engage in some public comments. So with that, I'll wrap us up at the end.
Mark.
But
Mark.
Sure, Bob. Yeah.
Bob, just a request. I'd love to see circulated back to the commission and maybe to the public, both Richard's 7 points and Bill's 6 points, or maybe there's the other way around, but I'd love to see those come back to the commission. I'd like to noodle on those.
Sure. Okay, Karen, I'm going to turn it over to you to help us through public comment. As always, commissioners, please stay on for till the end, and we'll wrap up at the very end. Thanks.
Thank you, Secretary Galley. And I just want to appreciate Commissioner Desert's input via chat at the end. We apologize for her technical difficulties and thank you for sharing via chat. Chat is now open to the public for written comment, as is the email address we stated earlier. We'll also be taking verbal comment now for those who have virtual raised hands. Please keep your comments to no longer than 1 minute, as we're trying to accommodate as many members of the public as possible today. I will remind you when your time is up, my apologies in advance. If you continue, I will move on to the next speaker again so we can accommodate as many voices as possible. When I invite you to unmute, please state your name and any affiliation you have that's relevant to the conversation. All right, and with that, we'll kick things off with Cindy Young. Please go ahead.
Thank you, commissioners, and thank you very much. My name is Cindy Young, and I'm Vice Chair of Healthy California Now and serve on the Board of Directors of CARA. I'm speaking to you today as actually a Cindy Young, because I want to tell you I took care of my parents in my home for 16 years. My mom lived till she was 92 and my dad until he was 97 and a half. We didn't want my parents in a Medicaid facility, although they would have qualified. We actually took care of them in our home because we wanted them to be under our care and love. So I can't speak loud enough about getting long-term care incorporated into a unified financing system. I never felt like I did anything well. I didn't feel like I did my job well. I didn't feel like I took care of my marriage. I didn't feel like I took care of my friends or myself. So it's impossible to meet all the demands without having someone come in and help you. So I encourage you to move forward on this path.
Ms. Young.
Yep. Thank you.
Thank you. Thank you very much. Michael Leidy, please go ahead.
Thank you, Karen. Thank you, commissioners, for a really robust discussion. Michael Leidy, President of Healthy California Now. I think an effective transition requires establishing an infrastructure for controlling costs, lowering costs, negotiating rates, setting global budgets, and a state healthcare budget. Really, an effective transition must begin with the elimination of barriers to care, including networks that limit access and eliminating out-of-pocket costs. In my view, there's no legitimate role in the transition or a new system that for entities that allocate care based on financial risk or restrict access to care based on financial incentives. Integrated care delivery that based on insurance risk or anti-competitive consolidation of hospitals or purchase of medical groups by hospital systems for revenue maximization is not efficient and diverts resources from patient care and raises costs. Care coordination and equity, the elimination of barriers to access based on equity is essential, and care coordination, particularly for low-income people and people with chronic conditions, is essential.
Thank you, Mr. Leidy. Thank you so much. Bill Honigman, please go ahead.
Thank you. Can you hear me?
Yes, sir.
As a retired ER physician from Orange County, I recommend the following for a smooth and just transition to universal care under unified financing. Number one, workers in health insurance claims processing can be readily retrained from deniers of care to facilitators of care, ensuring patients receive the treatments needed to prevent more complex and therefore more costly conditions. Number two, long-term care like dental, vision, and hearing, addiction care, and behavioral health care are all health care and must be included, again, to avoid more costly care due to neglect. Number three, as COVID-19 has shown us, time is of the essence. As the longer we delay, the more costly these conditions become, with more suffering and preventable deaths as a result. Number four, proposals for needed revenues have long existed and require only your prioritization. Finally, number five, use existing legislation as template. AB 1400 has all the mechanisms to take care out of the hands of third parties and place it in the capable hands of patients and providers. Thank you.
Thank you very much. Thank you. Terry Brady, please go ahead.
Thank you. I am the chair for the Foothills Coalition for Universal Healthcare, and I'll try and keep my comments brief. Commissioner Wright and Comsty, as well as others, were correct in pointing out the significant need to start the necessary transition steps now. This much needed reform must not be shortchanged by not providing the needed resources that must be applied to be successful with the transition. Traditionally based on many, many years of corporate project management experience, the area that most frequently kills the success of a project of this magnitude is the choice or lack of willingness to apply the needed resources to facilitate success. Typically, most management organizations try to cut corners to save money and end up with significant failure to reach even the basic goals. We must start now to prepare a detailed funding and implementation plan. We must start preparing now for transition, not years from now, which would almost surely lead to failure, disillusionment for a critical issue that must be addressed.
Thank you, sir.
We are serious about addressing the health needs of all.
Thank you. Ryan Skolnick, please go ahead.
Thank you. Ryan Skolnick with the California Nurses Association. And I can't emphasize enough how important it is that we stop acting like the current managed care model has any place in a system that wants to guarantee healthcare as a human right. Managed care under our current system is predicated on the notion that the ideal way to reduce healthcare costs is to use payment schemes to encourage providers to provide less care. You cannot reconcile healthcare as a human right with payment schemes that discourage providers from providing care. For this reason, capitation and other risk-based payment schemes are the antithesis of guaranteeing healthcare as a human right. And they also miss the point. Our costs are sky high because of prices, not overutilization. Those sky high prices are a natural consequence of a system that tries to play nice with both the free market and public health. Those interests can never be reconciled. The free market wants to pay out as little in claims as possible. Patients want the care they need. They're diametrically opposed, and I want the commission to decide if they want to side with profit-seeking middlemen or the health of Californians. They cannot do both.
Thank you very much. Robert Vinetz, please go ahead. Mr. Vinetz, would you like to unmute and speak, sir? All right, we better move on. Philip Kim, would you like to go ahead?
Can
Oh,
you
there he
hear me?
is. Yes, sir. Please go ahead.
Can you hear me?
Yes, sir.
Great. I am not sure what happened, but I am a retired pediatrician with about 45 years in primary care and 3 years in public health, almost all of them serving low-income people. I'm also a member of the California Physicians Alliance. And the main message I want to give you today is that I urge you to read the California Physician Alliance Roadmap to Golden State Care. It is a focus exactly on the transition that the commission has been discussing today. And it includes hundreds and hundreds of hours of deep thought and expertise in creating the roadmap. It includes 3 phases, and each phase includes legislative and non-legislative system changes, policy, values, and attributes.
Thank you, Mr. Vinetz.
I think it will really help you. Thank you so much.
Thank you. Philip Kim, please go ahead.
Thank you. Hi, Philip Kim with the California Nurses Association. I'm in Sacramento. Regarding a speedy transition to unified financing, the commission should not stick to our current flawed set of payment systems merely because you're worried that providers cannot handle change. Transitioning to a unified finance system of any kind will require providers to change how they manage payments. However, providers are well equipped to make such a change quickly because they have to do it constantly now. Under our current multi-payer system, providers juggle dozens of different federal and private payment schemes that each make frequent changes, even within managed care and capitation models. Furthermore, complexity in these flawed risk-based payment schemes create massive administrative burdens on doctors, nurses, and other healthcare professionals. Transitioning to a single payer means that providers will only have to deal with one set of rules and far reduced administrative burdens. So switching to a single stable system like CalCare AB 1400 will make providers' lives easier and free up their time and energy to provide better care to all Californians. Thank you.
Thank you, Mr. Kim. Isabel Story, please go ahead.
Hi. Yes, I'm representing Indivisible California, a coalition of 80 groups across the state. We believe that the transition to a single payer system needs to be done as quickly as possible. There are 3 million Californians with no insurance, millions more underinsured, and we're still in the midst of a deadly pandemic. And as Carmen Comsty mentioned, the transition to Medicare just took 1 year. And we already have a plan for single payer healthcare system that would fulfill the mission of this commission. It's AB 1400. This legislation needs to be included in the commission's final report. In fact, in order to transition to a single payer system, legislation such as AB 1400 needs to be passed to apply for the federal waivers. So the commission needs to emphasize that passing state legislation is a crucial step in the plan to transition to unified financing.
Thank you.
And finally, we think long-term care should be included in the plan.
Thank you very much. Farah Mars, if you could unmute and state your full name, please go ahead.
Yes, please recommend a rapid transition to single payer. I'm one of 3 million Californians who's uninsured. Private health insurance is built on the denial of care. Financial incentives that restrict care cause poor people not to get the care they need. Given the disproportionate poverty among Black and Indigenous communities, it's a cause of the disparate medical outcomes we see. Medical debt is the top cause of bankruptcy. And even those with insurance delay care because they can't afford the copays and deductibles. A single payer system like AB 1400 would eliminate these barriers, so self-imposed delays in care related to affordability would no longer occur. And this personally affects me as someone who can't afford care right now. Single payer lets people keep their providers, not worry about the insurer dropping them. So a rapid transition would prevent insurers from dropping patients, raising prices, and denying reimbursements and services. So
Thank you.
Thank you. Please move as many as possible at the same time for bargaining power. Thank you.
Thank you. Robin Sunbeam, please go ahead.
Themselves there.
There you go.
Here I am. Hi, I'm Robin Sunbeam, and I'm a member of National Nurses United. I'm a professional, long-term service professional. I do nursing assessments on people applying for long-term care. I see two classes of people, the rich and union members. At this time, only the rich can afford the prohibitively high premiums for long-term care insurance. Otherwise, I see retired bus drivers and janitors and school secretaries, all union members, with the CalPERS union benefit of long-term care. They're the lucky ones. It's clear that everyone, all of us, are going to need long-term care, especially now that the birth rate has gone down and so many single people live alone who don't have children to take care of them. So,
thank you, Ms. Sunbeam.
Oh, my minute is over? Okay,
Yes.
well,
Thank you very much. Jenny Chang, please go ahead.
Hi, thank you. Thank you, Jenny Chun Hansen, for your human-centered presentation. Those who know you sing your praises. I have thoughts on Senator Pan's remarks. I think the 5% increase based on the existing for-profit system really just underscores the problem rather than the financial projections of for LTSS under a single payer system. I do think it is crucial to consider how much children's education and growth suffer when they're forced to grow up too soon because they are heavily involved in making sure their loved one is taken care of. In lower income families, it is so challenging and family members have to lean on each other so much more, and it can take great emotional and psychological toll, especially on younger people who may feel like they're perpetually drowning or that the fires at home are never out. So it can be immensely difficult for these young people as well to suddenly find independence, such as when they pursue college or other endeavors, and the graduation rates reflect that. LTSS would also benefit domestic workers, and we need to make sure they're paid fair wages for all hours worked, paid when the family decides to go on vacation, and make sure they have paid time off for their own sick children. Thank you.
Thank you, Ms. Chang. Thank you. Jeffrey Tartagia, please go ahead.
Yes, my name's Jeffrey Tartagia. I'm an advocate here in Sacramento. And OWL, HCA, Cal Care, other aspects is all being involved with. There needs to be a single payer, and as suggested, it needs to happen now. I will say to you, Mark Galway, is you don't have the patient there with you, and you're trying to solve the problem. I hope you get people involved, because there's a limited number of people that are here involved, and yet we're all pushing for something that needs to happen. 1,400 is a policy statement that the state of California needs to make, and the legislator needs to determine how to finance it. That's my comments and recommendations, that you get on the ball. And Richard, you're only here for another year. Make this happen. Figure out the way to do it. I'll wait for the rest of you.
Thank you. Hillary Sybins, please go ahead.
Hello, I'm a geriatrician and rehabilitation physician, physiatrist, and I volunteer with the California Physicians Alliance and am one of the co-authors of that document, first written in 2019 with the input of many healthcare experts and our physician and supporter membership. All you commissioners have received this phased approach, which resonates with a lot of the wonderful comments made by you commissioners today. And we target 5 key strategic areas, including universality, responsible insurer behaviors, cost and price, efficient public systems, improving upon Medi-Cal, and huge efforts are going on there, which we praise, as well as workforce development. I also would like to take exception to Professor Scheffler's way of framing of winners and losers. I shouldn't repeat that. As George Lakoff says, don't say it. We are all losers.
Thank you, Ms.
right now.
Sybins.
And let's all be winners. Thank you.
Thank you. Thank you very much. Betty Dumas-Toto, please go ahead.
Yes, hi. I just want to remind everybody, it's impossible until it's done. And it is a false narrative that in the richest country in the world, in the 5th largest economy in the world here in California, that we cannot afford to provide health care as a right to every resident of California, and in fact, the country. I recommend AB 1400 CalCare as the solution to our broken, fragmented, separate, and unequal system. It fulfills the mission to this commission's task, which it was tasked for us. And I will speak in for a friend of mine who struggles with long-term care, as she is an intergenerational caregiver of someone in kindergarten, someone getting ready for college, and someone taking care of an elderly father-in-law who suffers from kidney failure, diabetes, and bipolar disorder. She struggles taking care of all of these people on limited income. We need AB 1400.
Thank you very much. Carrie Madden, please go ahead.
Hello, I'm Carrie Madden from CalLife Independent Living Center in downtown Los Angeles and the LTSS Grassroots Coalition. And most health plans currently provide minimal to no coverage for LTSS, nor does Medicare. This forces people who require LTSS to rely on Medi-Cal, resulting in poverty being a precondition to qualifying for care. Even when a person does qualify for some LTSS coverage under Medi-Cal, there's an overwhelming bias towards institutionalization over home and community-based care, despite the desire of patients to remain in their homes and communities. Even then, when a patient does qualify for care in their home and community, they are often forced to wait for years to receive that care. That is why home and community-based care should be prioritized when including LTSS coverage under a unified financing, unless the patient explicitly opts out of institutional care. Thank you.
Thank you. Beatriz Sosa Prado, please go ahead.
Good afternoon. This is Beatriz Sosa Prado, Executive Director at California Physicians Alliance. To ensure a smooth transition to a public financing system, we need a roadmap that is strategic, approachable, and realistic. Going from the status quo to a unified system of public financing overnight would be nearly impossible because the legislative process just doesn't function this way. Even if it did, Such a giant leap would cause unwanted disruption to people that already rely on the healthcare system, like Medi-Cal beneficiaries, for example. A master plan for health is one approach, but because one doesn't exist, a phased roadmap is a critical building block. To support the commission in writing your final report, we encourage you to use CAPA's roadmap that lays out phased systems changes to create Golden State Care, a unified public financing system. These steps are not incremental, but pragmatic and sequential, to quote Commissioner Wright, that will lead us to a universal, equitable, affordable, and comprehensive, high quality and sustainable healthcare system. Thank you so much.
Thank you. Thank you. Marie Lopez, please go ahead.
Great. Thank you so much. Mari Lopez, California Nurses Association. The Commission should recommend a speedy transition to protect patients who are suffering under our current system and to reap the health benefits of a single system faster. Every day that single payer is not implemented, more people die from delayed or denied care, and more people are going into debt just to survive. And more of them are making life-changing decisions based on keeping health insurance. We cannot let health plans or insurers take advantage of delays in transitions by raising prices or by shutting down plans before the new system is fully implemented. Additionally, the new system will get the best savings by transitioning as many patients and providers as possible into the program at the same time. So the state has the best leverage to negotiate with providers. We need single payer now, and we shouldn't delay and leave room for patients to fall through the cracks in the interim by creating a long transition process. Thank you.
Thank you. Art Persico, please go ahead.
Thank you. Thank you, commissioners, for listening to the public today. My name is Art Persico. I'm with San Francisco Gray Panthers, California Alliance for Retired Americans, and Long-Term Services and Supports for All Grassroots Coalition in San Francisco. This commission's own modeling shows that LTSS can be fully covered under a unified financing system while achieving cost savings, and that covering all Californians, including full coverage of LTSS with no cost sharing, would save California money compared to our current system by year 3. Furthermore, a single payer unified financing system will save billions of dollars and allow the state to offer a comprehensive set of benefits, including LTSS, to every resident in this state. This is by far the best and most efficient way to pay for LTSS for all Californians who may need it. No more patchwork. And guaranteeing access to LTSS for all would ease inequity and the burden on families who are forced to provide unpaid care for their elders. Thank
you, Mr. Persico. Thank you. Larry Woodson, please go ahead.
Yes, can you hear me?
Yes, sir.
Okay, Larry Woodson, Chair, Health Benefits Committee for California State Retirees. We have 41,000 members. I've tied into all the meetings and appreciate the contributions and discussion of all the commissioners and the chair. There's one point that has not been addressed in these meetings, and that is that there are over 100,000 CalPERS retirees receiving health benefits living out of state. The single payer to date discussion has been for people living in California. A system must address how these elderly who've been promised health coverage will continue their benefits. If not, all those that are pre-65 would lose all their benefits, and all those on Medicare would lose their supplements. I'd ask the commission to please address this issue, short of asking people to move back to California. Thank you.
Thank you so much. We only have a few more minutes to take speakers, so if you are further down the queue, please feel free to begin adding your comments in chat. And with that, Brian Stomp, please go ahead.
Thank you. I'm Brian Stomp, Healthcare for All Marin. Thanks for the great job the commissioners are doing. If Saskatchewan and Canada, with an economy a small fraction of California's, could get single payer done and working so well that the rest of Canada followed, California can do it, and the rest of the United States will follow. The governor of Saskatchewan has 2 first names. That was Tommy Douglas. I think Tommy's probably gone by now, but he was voted by Canadians the greatest Canadian of all time. So if anybody says Canada doesn't like their health plan, the greatest Canadian of all time was Tommy Douglas. He got single payer going. Thank you.
Thank you. Sally Gwynn Satterley, please go ahead.
Yes, I'm Sally Gwynn Satterly. I am a retired registered nurse with, and I am still part of the CNA NNU retiree group. I'm also a co-leader of Medicare for All in Santa Cruz. This is very emotional for me. I've worked on this. Sorry, I've worked on this for 20 years. Sheila Kuehl brought up a bill for single payer 20 years ago, I think even longer. I have been working on this for that long. I've lost so many patients and friends because they couldn't get the health care that they needed. We have to transition quickly. People are dying. And please, AB 1400 is an excellent plan. Please discuss that and use that, and please support it. We must have health care that covers everyone, and we need to have care based on need, not
Thank you very
profit.
much.
Thank you.
Thank you. Susan Meyer, please go ahead.
Susan Meyer, California Alliance for Retired Americans. I live in Orange County, was my mom's caregiver for 7 years. I did the best I could while maintaining a full-time job to provide for my family. In the end, I had to take an early retirement from my job that I loved to care for my mom. Currently, only 4.2% of Californians have private long-term care insurance, which is far from comprehensive, and less than 1% have access to publicly funded LTSS benefits. Most people needing LTS cannot afford to pay for the services for the length of time they need them, and either run out of money, depend on family members to provide care without compensation, or spend down their resources to become eligible for public programs or placed into institutions. I believe that the best, most efficient, cost-effective way to provide an LTSS is as part of a statewide, single-payer, unified financing system.
Thank you very
all
much.
for all you're doing.
Thank you. And Jean Jackman will be our last speaker. Jean Jackman, please go ahead.
Thanks to all who have invested so much time, energy, passion, and wisdom on this issue. Please, AB 1400 is an answer to so many problems. It should be the template for the commission's recommendations because it addresses most questions the commissions have discussed. How we reimburse providers, how governance works, what the process would be. AB 1400 would fulfill the mission of the commission. Medicare transition took 1 year and people are grateful for Medicare. Let's move rapidly like the country of Taiwan did, and by so doing, save lives, save bankruptcy, save heartbreak. Please open your hearts and minds and move AB 1400 forward rapidly.
Thank you very much. Thank you. And with that, I'll turn it back to Secretary Galley to adjourn the meeting.
Terrific. Thanks, Karen. And thanks to all of the members of the public who had a chance to share public comment and those who did it in the chat. And to all the commissioners, thank you for taking time during this last meeting of this calendar year. Look forward to getting you the outline, getting feedback, and then working in the first couple months to get our report in a place we can all be proud of. Appreciate the conversation today, to the presenters, and just really the great back and forth. So with that, wish you all happy, safe, healthy December holiday season, and look forward to connecting with you in January. Take care, everyone.